যেখানটা আমরা শেষ করছিলাম, উইল বি স্টার্টিং ফ্রম দেয়ার। ইট ইজ ওয়ান অফ দ্য মোস্ট complex thing in human body, vestibular apparatus, and it is connected with cranial nerve number 8. Cranial nerve number 8. Complex কেন হচ্ছে? কমপ্লেক্স আরো বেশি হয়, মাঝে মধ্যে লোকজন ঢুকে আমাদেরকে তাকাতে হয়। এটা ভেস্টিবিউলার নিউক্লিয়াস করে বেসিক্যালি। তুমি যখনই মাথা এদিক থেকে এদিকে ঘোরাচ্ছ, ইয়োর ভিশনটা যদি ফিক্স রাখতে হয়, উই নিড ভেস্টিবিউলো অকিউলার রিফ্লেক্স, VOR। আর বডি যখনই এদিক ওদিক মুভ করছে, ইফ ইউ হ্যাভ টু কিপ ইউর ব্যালেন্স ইনট্যাক্ট, তাহলে আমাদের লাগবে ভেস্টিবিউলো স্পাইনাল রিফ্লেক্স। এই দুটো আসছে হচ্ছে ভেস্টিবিউলার নিউক্লিয়াস এবং ভেস্টিবিউলার অ্যাপারেটাসের থ্রু। This vestibular apparatus, it is present inside the inner ear. Inner ear, petrous part of the inner ear, but temporal bone তার মাঝখানে inner earটা রয়েছে। So there it is, and it is one of the most complex structure in human body. Maximally simplified আমি কি করতে পারবো? There are 3 semicircular canals, এবং এই যে 3 semicircular canals are at 3 different planes, x, y, z axis. এইভাবে জিনিসটা থাকছে। Remember this vestibular apparatus এর দুটো পার্ট, 3টে semicircular canal, and we have utricle and saccule. এই দুটো হচ্ছে otolithic organ. Utricle and saccule, these two are the otolithic organ. Why this is otolithic organ? Because they do contain certain calcium carbonate crystal. তাহলে ক্যালসিয়াম কার্বনেট ক্রিস্টাল প্লাস স্পেসিফিক জেল অ্যান্ড দি অর্গান, এই তিনটে মিলে তৈরি হচ্ছে অটোলিথিক অর্গান। দুটো রয়েছে, একটা উপরে একটা নিচে, হরাইজন, একটা ভার্টিক্যাল, হরাইজন্টাল, দিস ওয়ে দিস টু আর দেয়ার। অটোলিথিক অর্গান, ইউট্রিকল, স্যাকিউল। ফাংশন অফ অটোলিথিক অর্গান, এরা কি করছে? লিনিয়ার অ্যাক্সেলারেশন অর ডিসেলারেশন দে ক্যান সেন্স। So otolithic organ, they can sense linear acceleration and deceleration. এরা স্পিড সেন্স করে না, অলওয়েজ রিমেম্বার, স্পিড সেন্স করে না, অ্যাক্সিলারেশন সেন্স করে। স্পিড কিচ্ছু সেন্স করে না যতক্ষণ। Why? Because এখানে কি হচ্ছে, there is difference in inertia. There are 2 different rheologically active substances inside the organs. একটা হচ্ছে জেল ফর্মে থাকছে, the other in solid form. এদের মধ্যে ইনার্শিয়া চেঞ্জ হলেই only one will be, in opposite direction to the other. Only then this otolithic organ will discharge. Similar for the SCC, semicircular canal minus the otoliths. Semicircular canal এর মধ্যে we have the solid part, we have the gel part, but we do not have any calcium carbonate crystal. Function of semicircular canal is to sense angular acceleration and deceleration. একদম এটা এমসিকিউ এর জন্য, do remember otolithic organ, utricle and saccule, they sense linear or horizontal acceleration deceleration. কখন তুমি গাড়িতে যাচ্ছ, গাড়ি ব্রেক মারছে অথবা গাড়ি স্পিড তুলছে, অ্যাক্সিলারেট করছে, otolithic organ will act. তুমি লিফটে যাচ্ছ উপরে বা নিচে, otolithic organ will act. ঠিক আছে? semicircular canal যখন মাথা মুভ করছো, or there is a centrifugal or centripetal force, সেখানে semicircular canal will act. In most of the complex environment, semicircular canalটা কি করছে? semicircular canal angular acceleration, আর otolithic organ linear acceleration. এই প্রশ্নগুলোর জন্য রেডি থাকবে ইন দি ভাইভা, কারণ লিফটে যাচ্ছ, এলিভেটর, এগুলো প্রত্যেকটা। এবং মোস্ট অফ দ্য কেসেস জীবনে অনেকগুলো মুভমেন্ট আমাদের থাকে, যেমন গাড়ি যখন যাচ্ছে, দুটোই একসাথে কাজ করতে পারে। মুভ করছে গাড়ি, অ্যাক্সিলারেট করছে এবং ঘুরছে, দুটোই একসাথে কাজ করতে পারে। এত উঁচু এত হাই লেভেলের বাইক যেগুলো বেরিয়েছে, হার্লি ডেভিডসন, এত দাম দিয়ে কিনছো, দুটো অর্গান একসাথে কাজ করবে না হয়? তো একসঙ্গেই সেটা অ্যাক্সিলারেট করছে অ্যান্ড টেকিং আ টার্ন, ওটা কাজ করছে। অনেক সময় দেখা যায় কাজ করে না লোকটার, ওই জন্য একটু পরে নিচে পড়ে থাকে, দুজন বাইক এবং ব্যক্তি পড়ে আছে, প্রপারলি কাজ করেনি। এনিওয়ে, সব জায়গাতেই কর্টেক্সকে কাজ করতে হবে, এদের অনেক সময় কর্টেক্স কাজ করে না। যদি নিউ টাউনের রাস্তায় যদি 250 কিলোমিটার স্পিড যে তুলছে, তার সেমিসার্কুলার ক্যানাল হয়তো কাজ করছে, কর্টেক্সটা কাজ করছে না। সেরিব্রাল কর্টেক্স হতেই পারে, কিছুক্ষণ পর দেখা যাচ্ছে কিছুই কাজ করছে না, পড়ে আছে নিচে। ইট ক্যান হ্যাপেন। যাই হোক, তো এই যে 3টে সেমিসার্কুলার ক্যানাল আছে, এর নিচের পার্টটা আবার অ্যাম্পিউলা, আগের দিন লেখানো, এই পার্টটা সোলেন, এটার নাম ছিল অ্যাম্পিউলা। আর পুরো স্ট্রাকচারটা এরকম দেখতে একটা স্ট্রাকচার। এখানে পিছনের দিকে কক্লিয়াটা যে 2.5 টার্ন যেটা রয়েছে, সেইটা পিছনের দিকে রয়েছে, দ্যাট ইজ ফর হিয়ারিং, অর্গান অফ কর্টি অ্যান্ড স্টপ, সেটা আমার আজকের ক্লাসের ব্যাপারই না, দ্যাট ইজ সেপারেট। হিয়ারিং ইজ সেপারেট, ব্যালেন্স নিয়ে আমাদের কথা হচ্ছে। এইবারে উই নিড টু ডু ওয়ান থিং, we are making a magnified cross section. If I draw a cross section, it will look like this. Okay, and there will be a membrane part. This part er moddhe in the tube, membrane part er moddhe inside we have a specific that is known as retinolin. The membrane part is almost equivalent to plasma. ফলে প্লাজমাতে সোডিয়ামের যা কনসেন্ট্রেশন, পটাশিয়ামের কনসেন্ট্রেশন, viscosity is almost equal. Perilymph is equivalent to plasma, you can think like that. Endolymph is different. It is more of a gel-like structure, so viscosity is high. Potassium level high, sodium level low. Endolymph is structurally, chemically different from plasma, and that is needed. Otherwise, যখন আমরা মুভ করছি সেই সময় এন্ডোলিম্ফ যেদিকে মুভ করছি সেদিকে চলে যাবে, if it is not a heavy fluid. Since endolymph is a heavy fluid, whenever you are moving your head, endolymph will move later. So initially endolymph will try to be stationary, you are moving your head. Endolymph is stationary means endolymph is pressurizing on the opposite direction. ক্লিয়ার হয়েছে প্রত্যেকের? তাহলে যদি আমি মুভ করছি, ধরো দিস ইজ মাই রাইট সাইডেড সেমিসার্কুলার ক্যানাল, ইফ আই মুভ লাইক দিস, পেরিলিম্ফের মুভমেন্টটা এদিকেই থাকবে, আই এম লুকিং টু দ্য রাইট, বাট এন্ডোলিম্ফ উইল স্টে হিয়ার। সিন্স এন্ডোলিম্ফ ইজ স্টেইং হিয়ার, হোয়াট উইল হ্যাপেন, এই পার্টটাও তো মুভ করছে এদিকে, এন্ডোলিম্ফ ইজ স্টেইং হিয়ার, সো দেয়ার উইল বি অ্যান এক্সট্রা প্রেশার অন দিস। দিস ইজ দি বেসিক্স অফ দি sensation of the vestibular part of the eighth nerve. Clear? আরেকটু ডিফিকাল্ট জায়গাতে আছি। নাও দিস এরিয়া, ইট ইজ অলসো an engineering marvel. কিরকম হচ্ছে, গুলোর মধ্যে there are two different distinct class of hair cell. One is short brush of hair cell, যেগুলোকে বলা হয় স্টিরিওসিলিয়া, and there is one long tall brush নয়, সিঙ্গেল একটা লম্বা একটা সিলিয়া রয়েছে, দ্যাট ইজ নোন অ্যাজ কাইনোসিলিয়া। তাহলে দু ধরনের আছে, ওয়ান ইজ স্টিরিওসিলিয়া, ছোটগুলোকে বলা হচ্ছে স্টিরিওসিলিয়া, অ্যান্ড এটার নাম হচ্ছে কাইনোসিলিয়া, যেটা টল যেটা সেটা হচ্ছে কাইনোসিলিয়া। দিস ওয়ান ইজ দি কাইনোসিলিয়া, বাকিটা হচ্ছে স্টিরিওসিলিয়া। আরো ডিফিকাল্ট, যদি পিজি লেভেলে ইফ উই গো, দেয়ার ইজ সামথিং কল্ড টিপি লিঙ্ক, এই জায়গাতে রয়েছে, ওয়াইফাই এর নাম নয়, এখানেও রয়েছে একটা জিনিস, সো দেয়ার ইজ সামথিং কল্ড দ্যাট। এবং তোমাদের, আমি জানি না তোমাদের মনে আছে কিনা, ডু ইউ রিমেম্বার মলিকিউলার মোটরস? কিছু মনে আছে? কাইনেসিন, ডাইনিন, তো এখানে মলিকিউলার মোটর মলিকিউলস আর ওয়ার্কিং, স্প্রিং লাইক স্ট্রাকচারস ওয়ার্কিং, এই জিনিসটাও রয়েছে। এতটা এক্ষুনি লাগবে না, জাস্ট বেসিকটা কিছুটা আমরা এখানে করছি। এই যে সিলিয়া, এর উপরেও একটা জেল লাইক স্ট্রাকচার আছে, উই কল ইট কিউপিউলা। এর উপরেও যে জেল লাইক স্ট্রাকচার আছে, উই কল ইট কিউপিউলা। যখনই আমি রাইট সাইডে মুভ করছি, উইল সে ইট 2 to 3 times, whenever I am moving towards right, endolymph is stationary, endolymph is pressurizing towards the left, because movement of endolymph starts later, it has a different inertia. Whenever endolymph is pressurizing to the left, you see the direction of the pressure is towards the kinocilium. So what will happen? This gel will bend towards the kinocilium. Clear? Endolymph to kinociliar upor direct pressure দিচ্ছে না, because this is covered in a cap of gel. So endolymph is pressurizing on the cupula. So cupula is bending towards the kinocilium. কিরকম লুকসটা আসছে? Normally it is like this. This is the normal scenario. Whenever we are looking to the right, it is like this. Clear? Whenever we are looking towards right, it is like this. যে মোমেন্টে এই জিনিসটি ঘটছে, so when you are moving towards right, kinocilia is bent towards left. Clear? When cuneiform is bent towards left, why cuneiform is bent towards left? Because gel is pressurizing towards the cuneiform. And when this happens, this pressure response or physical force is converted into action potential. এই অ্যাকশন পোটেনশিয়ালটা হয় বাই দি হেল্প অফ দিস স্টিপলিং, কিন্তু ওইখানে আমি আজকে আর যাচ্ছি না। জাস্ট রিমেম্বার, যখনই the gel will be moving or bending towards chymosylia, there will be depolarization. In the opposite side, the picture will be different. Opposite side e kirokom hobe movement ta, it will be away from the chymosylia. So যখন opposite side e, whenever it is happening away from the chymosylia, there will be hyperpolarization or repolarization. Try to understand. তাহলে cynociliar দিকে if it moves, depolarization, positive current. Chymosylia থেকে opposite এ move, repolarization or hyperpolarization means negative current. তার মানে whenever you are moving towards the right, brain understands I have to do things on right and don't have to do or switch off all the things on the left. Clear everybody? পুরো জিনিসটা এইভাবে হচ্ছে। তাহলে এই দিকের যে স্ট্রাকচারটা এঁকেছি, the same structure in a mirror position on the opposite side. রাইটে মুভ করলে কাইনোসিলিয়ার দিকে রাইট সাইডে বেন্ট হচ্ছে, অপোজিট সাইডে কোন দিকে, অ্যাওয়ে ফ্রম দি কাইনোসিলিয়া মুভ করছে। সো whenever this side on this side, so depolarization on this side means is positive current, there is negative current. এই জিনিস ম্যাচ না করলেই নিস্ট্যাগমাস হবে, দুদিকে চোখ এক জায়গায় ব্যালেন্স করবে না। এই জিনিস ম্যাচ না করলেই, তুমি এদিকে মাথা ঘোরাবে, মাথাটা ঘুরতে থাকবে। আমাদের যখন এই জিনিসটা ম্যাচ করে না, দ্য মোমেন্ট, অনেকে বলে দেখবে পেশেন্ট এসে এদিকটায় ঘোরালাম, মাথাটা মনে হচ্ছে ঘুরছে, কখন? বিকজ দিস ইজ নট ম্যাচিং, হারমোনিয়াস নেই। না থাকলে ব্রেন উইল বি গেটিং কনফিউজিং সিগন্যাল, কি আমাকে কি রাইটে তাকাতে হবে না লেফটে তাকাতে হবে, আমাকে বডিটা কোন দিকে করতে হবে। যখনই কনফিউজিং সিগন্যালস আর দেয়ার উইল বি রিলিং অফ হেড অর আনইউজুয়াল ফিচার্স। ক্লিয়ার এভরিবডি? এমনি বডিতে নর্মালি দিস টু আর পারফেক্টলি ইন ব্যালেন্স, এদিকে যতটা কারেন্ট হবে এদিকে ততটাই কারেন্ট হতে হবে নর্মালি। ডিফারেন্ট ডিজিজ লাইক বিনাইন পজিশনাল ভার্টাইগো, এই টাইপের যে ডিজিজগুলো রয়েছে, এই ডিজিজগুলোতে গিয়ে অর ইউনো ভেস্টিবুলার নিউরোনাইটিস, মানে ভেস্টিবুলার নিউরন তার ইনফ্লামেশন, অনেকগুলো এরকম ল্যাবাইরিনথাইটিস, এই টাইপের যে ডিজিজগুলো রয়েছে, দ্য পেশেন্ট উইল কমপ্লেন অফ ভার্টাইগো। ভার্টাইগো মিন্স রিলিং অফ হেড, মাথাটা ঘুরছে মনে হচ্ছে। কেন মনে হচ্ছে? ওর একটা পিকুলিয়ার সেন্সেশন, বমি পাবে মনে হচ্ছে, পিউকিশ, দে আর ফিলিং পিউকিশ। হোয়াই? বিকজ দিস টু রেসপন্সেস আর নট ইন ইউনিসন। যখন থাকবে না সাথে সাথে এই জিনিসটা হবে। অনেকের ক্ষেত্রে দেখা যায় ইন কেস অফ মোশন সিকনেস, যখন এই মোশনটা হচ্ছে, দিস আর ওভারটলি সেন্সিটিভ, তো এক্সেসিভ সিগন্যাল তৈরি হচ্ছে অ্যান্ড দে আর ফিলিং পিউকিশ। সেটা মোশন সিকনেসটা কখন? যখন এগুলো প্রপার ওভার্ট সেন্সিটিভ। নর্মালি গাড়িতে চললে তো হওয়া উচিত নয়, টিল দ্য টাইম আওয়ার ইউট্রিকল অ্যান্ড স্যাকিউলার ইন ইউনিসন, কিন্তু যে মোমেন্টে রেসপন্স ইজ নট ইন ব্যালেন্স, দিস মাইট হ্যাপেন। মোশন সিকনেসের ক্ষেত্রে সেটা হয়, অনেকের থাকে। আবার একটু বয়স বাড়তে বাড়তে দেখা যায় যে দ্যাট হ্যাজ বিন ভ্যানিশড। ক্লিয়ার এভরিবডি সোফার? এইবারে জিনিসটা আরো কমপ্লেক্স। সোফার হোয়াট উই হ্যাভ আন্ডারস্টুড, we have semicircular, this is the thing that you need to remember, semicircular canal and utricle and saccule. Semicircular canals are for angular acceleration. There are 3 semicircular canal on either side, each in 90 degree to the other. They are at x, y and z axis because it's a 3-dimensional plane. তার মধ্যে উপরেরটা horizontal acceleration, এইটা vertical, এটা linear এই সাইডের acceleration, all are angular, but the directionটা আমি বলছি, আর এটা হচ্ছে oblique acceleration and deceleration they can sense. Semicircular canals do have cilia, that is hair cell, and gel-like structure like cupula. Whereas the otolithic organ has gel-like structure, cilia and otoliths. Otoliths are nothing but crystals of calcium carbonate. Otolithic organ যেটা হয়, similar movement এ not only gel but the crystal of calcium carbonate is also putting pressure on the cilia. Just জিনিসটা যদি এভাবে দেখি, if we look at otolithic organ, it is like this. Cilia is the gel structure over here, and বোঝার চেষ্টা করো, যখন somebody is lying flat, what is happening? Like this, more otolith will be below. So these otoliths are helping in bending the cilia. যখনই তুমি শুয়ে থাকছো তোমার যেটা ভার্টিক্যাল এরকম কন্ডিশনে যেটা ভার্টিক্যাল শুলে তো সেটা হরাইজন্টাল হয়ে যাচ্ছে, ক্লিয়ার? যখনই চেঞ্জ হচ্ছে পজিশন, so this otoliths are sensing the gravity going down. As they are going down, the lower cilia will bend even more, কারণ নিচের দিকে otoliths concentration বেশি হয়ে যাবে, clear everybody? And the moment this is happening, again there is depolarization. ক্লিয়ার? প্রত্যেকে এই জিনিসটাতে অটোলিথিক অর্গানগুলো একটু ডিফারেন্টলি কাজ করে বিকজ অফ দিস। ইউ মে আস্ক হোয়াই অটোলিথস আর গিভেন? বিকজ দ্য সাপোর্ট অফ semicircular canal, so much of gel is not present, only limited amount of gel is present. To make the whole thing functional, we need to give certain extra dots inside. Clear everybody? দুটো অর্গান জাস্ট, কিন্তু কাজটা একই, ইনার্শিয়া চেঞ্জ হলে অ্যাকশন পোটেনশিয়াল হবে। In almost all the condition, if there is a bend towards the cilia, depolarization. If there is a bend away from the cilia, hyperpolarization. So this way brain can understand which direction actually things are happening. Clear? এ অবধি প্রত্যেকের ক্লিয়ার হয়ে গেছে? And otoliths are for the linear acceleration and deceleration. এবার আরো ডিফিকাল্ট জায়গাতে যাচ্ছি, তোমরা একটা জিনিস নিজেরা টেস্ট করে দেখতে পারো। এভরিবডি ক্যান ফলো, না? বুঝতে পারছো তো? ধরো যে কোনো হাতে একটা পেন নিয়ে ইউ জাস্ট কিপ ইট অন ওয়ান সাইড এবং এই সোজা মাথা রেখে জাস্ট ট্রাই টু লুক অ্যাট দ্যাট পেন। তাহলে ওয়ান আই ইজ ল্যাটারালি ডিভিয়েটেড, দি আদার আই ইজ মিডিয়ালি ডিভিয়েটেড। ক্লিয়ার এভরিবডি? হ্যাঁ, এই জিনিসটা কে করছে? হু ইজ কোঅর্ডিনেটিং দিস? ওয়ান আই ইজ ল্যাটারালি ডিভিয়েটিং অ্যান্ড দি আদার আই ইজ মিডিয়ালি ডিভিয়েটিং। কে কোঅর্ডিনেট করছে এটা? ল্যাটারাল রেক্টাস moving towards, suppose amar khetre this is my right hand, okay, this chalk is on my right side. Jodi chalkta amaye dekhte hoy tale right eye er lateral rectus is moving to the right side, abduction hocche right side er hocche. Similarly left side e medial rectus ke chalker dike takate hocche, tale left side e adduction hocche. Both should be equal, noile to ami duto dekhbo, otherwise diplopia will happen. So what is exactly happening here? Abduction and adduction is balanced. Lateral rectus ke move korache? Who? Sixth nerve. Medial rectus left eye te ke move korache? Third nerve. So there must be some connection between 6 and 3. Sixth nerve and third nerve er moddhe kono ekta connection thaka uchit. Clear everybody? This is known as MLF, medial longitudinal fasciculus. এই 6th and 3 তার কানেকশন হচ্ছে medial longitudinal fasciculus. We are going into even more complex area. তার আগে পুরো জিনিসটা মাথায় রাখবে এবং খেয়াল রাখবে পুরোটা it is a connection between 8th nerve nucleus, 6th nerve nucleus, 3rd nerve nucleus. সার্কিটটা আমি এক্ষুনি ড্র করব, বাট দিস উইল বি টু কমপ্লেক্স। ক্লিয়ার? এই জায়গাগুলো থেকে পিজির কোশ্চেন আসে, এই জায়গাগুলোই এতটাই ডিফিকাল্ট থাকে লোকে পড়ে না, বেরিয়ে চলে যায়। ক্লিয়ার এভরিবডি? তাহলে লেট আস কাম ব্যাক। এটা কি ছিল? হোয়াট ইজ দিস? বলতে থাকো। cilia, whatever cilia it is cilia. Top of it there is a gel structure. This side there is an endolymph. And by now you know whenever I move my head that side, there will be difference in inertia, there will be bending of the cilia, there will be some kind of change in polarity, be it depolarization, be it hyperpolarization. Whenever depolarization is happening, what will happen to the nerve which is supplying it? Action potential will be generated. Action potential, body kintu kichu boje na, it's a binary system. Action potential ache ki nei, that's it. Binary, 1 and 0 diye jemon gota computer language lekha, সেরকম বডির ক্ষেত্রে if there is an action potential, thing will happen. If there is no action potential, nothing will happen. Clear everybody? তাহলে ও তো আর এমনি কিছু বুঝছে না, আমি যেটা চিন্তা করছি, even that is sending a signal downward and movement of hand is happening. এটা কি action potential? সেটাই তো যাচ্ছে nerve impulse way. Everybody can follow? So similarly, which one is this nerve? This এই নার্ভটা কি? Which nerve is this? 8th nerve? This is 8th nerve, na? Vestibulocochlear nerve, vestibular part of the vestibulocochlear nerve. Clear? Everybody, we are making it more complex, or we are not making it complex, it is complex. One of the finest arrangement in our human body. Clear to you? So this is the 8th nerve. So all the bending things are creating a depolarization and action potential in 8th nerve. এই অবধি প্রত্যেকের ক্লিয়ার? এবার আরো কমপ্লেক্সে যাচ্ছি, তাহলে 8 নার্ভটা যাচ্ছে কোথায়? দিস ইজ গোয়িং টু 8 নার্ভ নিউক্লিয়াস। কোথায় আছে 8 নার্ভ নিউক্লিয়াস? ব্রেন স্টেম। কোথায় আছে? ব্রেন স্টেমে আছে। তো পন্স অ্যান্ড মেডালা জংশনের ঠিক নিচে, কর্নোমেডালারি জংশনের নিচে, মেডালার মধ্যে বলে নিতে পারি, দা অলমোস্ট ক্লোজ টু মেডালা এই আমাদের 8 নার্ভের নিউক্লিয়াসটা রয়েছে। হলো কিরকম ভাবে আছে? সো দিস ইজ দি 8 নার্ভ নিউক্লিয়াস। সো 8 নার্ভ নিউক্লিয়াসেরও ডিভিশন আছে, এনিওয়ে টু দি মিডিয়াল পার্ট ইট ইজ গোয়িং। সিমিলারলি ফ্রম দি পন্স লেভেলে 6 নার্ভ নিউক্লিয়াস আছে, যেটা কন্ট্রাল্যাটারালি এটার সাথে কানেক্টেড আছে। অন্যটা বন্ধ। কেন বন্ধ? কারণ এই হাইপারপোলারাইজ হয়ে রয়েছে, সুইচ অফ করা আছে, অন্যটা ওই জন্য বন্ধ। ক্লিয়ার হলো? এইটা যদি ঠিক কাজ না করে তাহলে ইউ উইল বি হ্যাভিং নিস্টেগমাস, কাঁপতে থাকবে লাইফের মতনই। আমি ওদিকটা যাবো না এদিকটা যাবো, যখনই প্রবলেম হবে দেখবে ইউ উইল লিটল বিট দেয়ার উইল বি শেকি মুভমেন্ট। যদি ইফ ইউ আর শিওর যে ওই দিকেই যাবো, তাহলে দেয়ার উইল বি সাম গেইন, দেয়ার উইল বি সাম লস, কিন্তু আমি ওই দিকেই যাবো। সো উইথ অল দ্য গেইনস অ্যান্ড লস, অল দ্য রেসপন্সিবিলিটি, আই উইল মুভ দ্যাট। অ্যাট লিস্ট ইউ উইল নট বি শেকি। কিছু জিনিস হবেই না, কিছু জিনিস হবেই, কাইন্ড অফ দ্যাট। বডি ইজ অলসো মেড আপ লাইক দ্যাট। ক্লিয়ার? এই পুরো সার্কিটটা ক্লিয়ার হলো? দিস ইজ ফর ইউর পিজি এন্ট্রান্স। যে কোনো এন্ট্রান্সের ক্ষেত্রে দিস কাইন্ড অফ কোশ্চেন্সের লেভেলটা এই জায়গাটায় দাঁড়ায়। টেক আ স্ন্যাপশট ইফ পসিবল, ওয়ান অফ দ্য মোস্ট কমপ্লেক্স স্ট্রাকচার ইন ইউর সিলেবাস। এইটা ভীষণ একটা কমপ্লিকেটেড জায়গার মধ্যে আমাদের আসছে। ক্লিয়ার? এটা কি, এটাকে কি বলা হচ্ছে? কোঅর্ডিনেটেড মুভমেন্ট অর কনজুগেট মুভমেন্ট। This is because of third six interconnection, medial, longitudinal, fasciculus. কিছু ক্ষেত্রে occasionally remember, there is a stroke in midbrain. If there is a stroke in midbrain, what will happen? This medial longitudinal fasciculus doesn't work. So this medial rectus, lateral rectus একসাথে কাজ করে না, দুটো চোখই মনে হয় যেন একটা অন্যদিকে ডিভিয়েট হয়ে রয়েছে। So stroke in midbrain এর ক্ষেত্রে medial longitudinal fasciculus may not work. So this conjugate movement of eyeball, that will be lost. That reaction will be lost. Patient কে বলবে এদিকে তাকাতে, দেখলে একটা চোখ ডিভিয়েট করছে, আরেকটা চোখ সোজা। That can happen যখন ওই মিড ব্রেনে গিয়ে তোমার স্ট্রোক হচ্ছে। প্রত্যেকটা উইকেন্ড ভেস্টিবিউলার স্ট্রোক হতে পারে, ভেস্টিবিউলার নিউক্লিয়াস, ব্রেন স্টেম স্ট্রোক হতে পারে। ব্রেন স্টেম স্ট্রোকে গিয়ে দেখা যেতে পারে, ইফ দেয়ার ইজ আ স্ট্রোক এট ব্রেন স্টেম, সাপোজ স্ট্রোক somewhere here, some CVA, some cerebrovascular accident, some infarction, ischemia, whatever that is happening over here, সাথে সাথে the patient will be complaining of vertigo, কারণ একদিক থেকে depolarization is perfect, from the other side hyperpolarization is not okay. So electrical stimuli from one side is perfect, from other side it is jittery. So what will happen? Body will again be very much confused what is exactly happening, and the feeling will be very unpleasant feeling of vertigo, vomiting, nausea, এই জিনিসগুলো সাথে সাথে হবে। ক্লিয়ার? ক্লিয়ার হয়ে গেল? তাহলে যদি ব্রেন স্টিম লেভেলে if there is a problem where 8 nerve is affected, feeling of vertigo, feeling of vomiting, যদি মিড ব্রেন লেভেলে এফেক্টেড হয়, তাহলে ডেফিনেটলি দ্য কানেকশন বিটুইন 3 and 6 there is a problem. So coordination will not be perfect. Chance of nystagmus will be there. Chance of nystagmus is also there যদি 8 নার্ভে গিয়ে প্রবলেম হয়, ডিপেন্ডিং অন দি লেভেল অফ লিশন। ক্লিয়ার এভরিবডি? নিস্ট্যাগমাসটা কি? অ্যাবনর্মাল জার্কি মুভমেন্ট অ্যাট দি এক্সট্রিম অফ, এন্ড ইট ইজ ইনভলান্টারি। তাহলে এরকম একটা সাইডে দেখতে গেলেই দেখা যাচ্ছে আই বলটা এরকম মুভ করছে, দ্যাটস আ জার্কি মুভমেন্ট। It can be horizontal, it can be vertical, it can be fast beating, it can be slow beating, lot of things. You have 10 years of your life to understand nystagmus. Again, another very difficult area, but if you just think right from the beginning in this line, it will be easier for you to grasp it in subsequent years. Clear everybody? Eta gelo third fourth er connection, medial longitudinal fasciculus. This way they are connected. This is one of the most important picture of your whole syllabus. Done. আমাদের অলমোস্ট we are done. একটু রিক্যাপিচুলেট করে দেবো for 5 to 10 minutes of the whole motor system. Any idea about the basal ganglia? What is the direct and what is the indirect pathway in the basal ganglia? What they do? কি কি পার্ট আছে basal ganglia? First of all, ওভারঅল সিএনএস এর যদি আমরা একটু রিক্যাপিচুলেট করে দিই, সিএনএস ইজ অল অ্যাবাউট সেন্সরি মোটর হায়ার, sensory motor higher plus always connected with the autonomic nervous system. CNS directly autonomic nervous system এর সাথে মানে autonomic nervous system is not the part of CNS but this is always coordinated. This must be coordinated. Okay. এইবারে sensory কোন পার্টটা sensory? Backward part, posterior part after the central sulcus, that is the sensory cortex. And motor cortex কোনটা? In front of the central sulcus, that is the motor cortex. Motor cortex has three very important area. One is the primary motor, then premotor, supplementary motor. Primary motor, premotor, supplementary motor. Plus, a part of somatosensory area, cortex, is also connected with motor cortex because unless you sense, you can't act. So 30% of fibers from somatosensory area, which is posterior to the sulcus, is connected to the motor system. And all these are connected via different interneurons. Motor system থেকে যখন কানেকশনটা বেরোচ্ছে, these are coming and they are from a larger, wider area, numerous fibers, axons are going down and forming the descending pathway. Since it is coming from the larger surface area, they look like a fan when they pass through a small tract. And this tract passes beyond the internal capsule, basically. এই যে ফ্যানের মতন দেখতে হচ্ছে, this is known as corona radiata because it is coming from multiple areas and it is getting a triangular shape. Apex is close to the internal capsule and it is going down. Anytime in nervous system, central nervous system, descending pathway is for motor, ascending pathway is for the sensory. This is very simple because you think over here and you do. হ্যাঁ, তার মানে এই নয় অনেকে হয়তো কিছু না ভেবেই অনেক কাজ করে, but that's different. তাদের ক্ষেত্রেও motor descending. Even if you don't have the cortex, it's still descending. Okay. আর sensory হচ্ছে you sense somewhere and it is coming back for the processing in the sensory system. Clear? এই জিনিসটা। Descending যে pathwayটা হচ্ছে তার অনেকগুলো ভাগ রয়েছে। Since it is starting from the cortex, so all the pathways are known as cortico something. Cortico something. Corticospinal means it is starting from the cortex and going to the spine. And in spine it is ending at the anterior horn cell of that particular level. Corticospinal গুলো কি করে? It is there দুটো পার্ট আছে. One is the lateral corticospinal tract, the other is ventral or anterior corticospinal tract. Remember the lateral corticospinal tract, it is for the descent and out. So distal muscle, এই যে foot hand, distal muscle এর জন্য or limb muscle এর জন্য lateral corticospinal tract, and they cross at medulla. কোথায় ডেকাসেট করছে? মাথাতেই হয়ে যাচ্ছে. They cross at medulla. So any problem which is happening on the left cortex will show motor deficit on right hand and right leg. দুটোতেই কি একরকম দেখাবে? Now the question comes there. এখন অবধি প্রত্যেকে ক্লিয়ার না? লেফট সাইডে, লেফট কর্টেক্সে, মাইকটা খুব অদ্ভুত বিহেভ করছে। হ্যালো, চেক। এটা ঠিক আছে? এই সাউন্ডটা ঠিক আছে? এইটা ঠিক আছে? এভরিবডি ক্যান, এইটা নইলে খুব জোরে হয়ে যাচ্ছে বেসিক্যালি। সো লেফট কর্টেক্সে যদি প্রবলেম হয়, রাইট লিম্ব উইল বি অ্যাফেক্টেড। হুইচ ওয়ান? আপার লিম্ব, লোয়ার লিম্ব অর বোথ? বোথ। আচ্ছা, এটার কি কোনো রকম ইয়ে আছে? এখানেও কোনো ম্যাথস আছে কি? আপার লিম্ব, লোয়ার লিম্ব না বোথ? এখানেও কোনো ম্যাথস? এখানেও আছে। ডিপেন্ডিং অন কোন সেরিব্রাল আর্টারি ইজ ইনভলভ তার উপর ডিপেন্ড করছে কতটা ডিফারেন্সিয়েটিং প্রবলেম আমরা দেখতে পারবো। ইফ ইট ইজ অ্যান্টেরিয়ার টেরিটরি, অ্যান্টেরিয়ার এসিএ টেরিটরি, লিম্ব উপর আর নিচের মধ্যে ডিফারেন্সিয়েশন থাকবে। ইফ ইট ইজ মিডল সেরিব্রাল আর্টারি টেরিটরি, সেখানেও লিম্ব উপর আর নিচের মধ্যে ডিফারেন্সিয়েশন থাকবে। তোমাদের জন্য কমপ্লেক্স আর করছি না, মাথায় রাখবে left side a problem, right limb a problem. Depending on whether front part of brain is affected or mid part of brain is affected or posterior part of brain is affected, degree of defect will be different in upper and lower limb. Clear? তাহলে সেই অঙ্কটা হচ্ছে কোন আর্টারি সেগমেন্ট গেছে তার উপর। If you know this by heart, just by looking at the patient, you can understand brain kothay lesion ache. You won't require a CT scan. Then you will just order CT scan just to confirm your diagnosis. We usually do the opposite, or we are trained to do the opposite. Actually, we should do this. First, you should look at, just by looking and examining the patient, you can, it is possible. CT scan er ageo treatment hoto, manusher stroke hoto, treatment hoto sei shomoy. So you can do that, and you can use the CT scan as a confirmatory diagnosis to your idea. What you want to see, you just see and confirm. Etai CT scan er reason howa uchit. Anyway, then the second thing is left side, right side ta holo anterior corticospinal tract এর ফাংশনটা কি? এটা ট্রাঙ্ক মাসলের জন্য বেশি কাজ করে. So this is more for the proximal and this is more for the central group of muscle. So whenever I am moving my hand like this, আমার center of gravity is changing in position. So আমি হাতটা এরকম মুভ করলাম, পুরোই পড়ে গেলাম. That should not happen. তার জন্য কি হচ্ছে, the other muscles, they have to adjust themselves in such a way the center of gravity remains intact and in a balance. So কি হচ্ছে, এখানে কাজ করছে anterior corticospinal tract. Usually 20 to 25% of all motor fibers goes into anterior corticospinal tract. They do not cross till the spinal cord, anterior corticospinal tract. And lateral corticospinal tract, they cross at the medulla and goes down. Clear everybody? Clear হয়ে গেল জিনিসটা? Corticobulbar tract টা কি? Cortex se start hocche, but it is coming to different bulbs or nucleus of different neurons, cranial nerves e nucleus er songe connect. Facial nerve, facial palsy tomra jano, connection kisher through te hocche. You are thinking ke you will laugh. So this is by corticobulbar pathway. The corticospinal noy, because this is above spine. So this pathway is corticobulbar. It is starting from the cortex and coming to the nerve nucleus. Cranial nerve nucleus এর সাথে এই জিনিসগুলো কানেক্টেড রয়েছে. ক্লিয়ার এভরিবডি? স্পাইনাল কর্ড কোন লেভেলে কি অ্যাডাল্ট স্পাইনাল কর্ড শেষ হচ্ছে? L1 L2, হ্যাঁ, তারপরে স্ট্রাকচারটা কি? Cauda equina. What is conus medullaris then? Same. Okay. End part, spinal cord এর end part, cauda equina মানে কি? Tail of a horse, তাই তো? হর্সের টেলটা তো দেখেছো তো, ইট ইজ জাস্ট লাইক মানে যেমন একটা কাইন্ড অফ আ ব্রাশ, তাই তো? কর্ডা ইকুইনা হচ্ছে ওই যে রেডিয়েশন গুলো বেরিয়েছে, দিস ইজ কর্ডা ইকুইনা। আর কোনাস মেডুলারিস হচ্ছে দ্য লাস্ট পার্ট, দ্য অ্যাকচুয়াল পার্ট অফ দি স্পাইনাল কর্ড। এইবারে ইন ফিউচার ইউ উইল বি গেটিং মাল্টিপল পেশেন্টস হু আর হ্যাভিং লিশন ইন কর্ডা কোনাস এরিয়া। কর্ডাতেও লিশন থাকতে পারে, কোনাসেও লিশন থাকতে পারে, অথবা কর্ডা কোনাস দুটোতেই লিশন একসাথে থাকতে পারে। কিভাবে হতে পারে? মেবি সাপোজ L1 which is big enough to compress on the cauda equina too, or L2 তে একটা টিউমার রয়েছে, সেটা কোনাসকে কিছুটা প্রেস করছে। L3 L4 এই সেগমেন্টটাতে প্রবলেম হয়েছে, অনলি কর্ডাকে প্রেস করছে, কোনাস ইজ আদার। ক্লিয়ার? সো ইউজুয়ালি এটা মাথায় রাখবে, এখন বোঝানো ইম্পসিবল, ক্লোজ টু ইম্পসিবল। Cauda lesion is usually UMN like feature দেয়, upper motor neuron like feature দেয়, because motor neuron ওই অবধি রয়েছে, spinal cord is still there. So all the segmental anterior horn cell and stuff যে ছবিগুলো আমরা আঁকি, that is present in the cauda, sorry, that is present in the conus medullaris, because that is the spinal cord part. Cauda is beyond spinal cord, so it is lower motor like features দেবে। cauda এরিয়াতে যদি হয়, cauda equina এরিয়াতে যদি হয়, তাহলে it will be giving a lower motor neuron like feature. Conus medullaris এরিয়াতে যদি হয়, it will give a upper motor neuron like feature. Upper motor neuron like feature মানে কি? What are the features? What is the difference between upper motor neuron and lower motor neuron? এটাই তোমাদের পরীক্ষার কোশ্চেন। So upper motor neuron, it will be tone will be high, reflex will be high or exaggerated, Babinski will be positive, upgoing will be the plantar. Clonus present or not? Upper motor neuron, clonus can be present in upper motor neuron. Clear? What will be happening to the hypertrophy of the or atrophy of the limb? Upper motor neuron e ki darabe? Partial atrophy, because all the time tone is high, so continuously some isometric exercise is happening in the muscle. Due to disuse, non-use of the limb, atrophy will happen. but due to isometric discharge continuously, atrophy will be prevented. So we'll get something in middle. Partial atrophy will be there. So atrophy will not, তুমি এরকম পাবে পেশেন্টের একটা সাইডের পা নাড়াতে পারছে না, but muscle both side is almost equal. You won't see any visual difference usually. Element lesion এর ক্ষেত্রে you will see there is a very different musculature. Polio patient চিন্তা করো, একটা limb short, একটা limb lean. You can see a distinct difference between the affected and non-affected limb in case of lower motor neuron. Because lower motor neuron ta je momente jacche, what is lower motor neuron? AHC downwards, anterior horn cell, and anything beyond that is lower motor neuron. So what is happening? Myoneural junction, not fine, the muscle, the nerve to muscle, nobody is working. If nobody is working for months, 7 দিন যদি কাজ না করে তাহলেই চেঞ্জ আসতে শুরু করে। So element lesion 7 days, এক সপ্তাহের পুরনো element lesion you will start seeing some visual differences. Muscle bulk টা কম হতে থাকে, and few months later it is absolutely দূর থেকে বোঝা যাবে একটা পা সরু। Clear everybody? একদম দূর থেকে দেখে তুমি পেশেন্টটা দেখে বুঝতে পেরে যাবে। তো caudal lesion usually তোমার element, conus lesion usually UMN features দেয়। এটা একটু এক্সট্রা বলা তোমাদের এই সময়, just UMN and element এর difference if you can identify, that is quite sufficient. Coming to pyramidal and extrapyramidal, যেগুলো খুব important. Pyramidal and extrapyramidal both are the part of motor system. So will it be ascending or descending? Descending. Of which pyramidal is for the voluntary. আমি হাঁটছি, আমি জানি আমাকে হাঁটতে হবে, that is voluntary. আমি হাঁটছি কিন্তু এটার ক্রস করছি না, because my basal ganglia is making a map and my cerebellum is giving an attestation to that map. এই জন্য ক্রস করে পড়ে যাচ্ছি না, কোথাও একটা ডিসফাংশন হলেই প্রবলেম হয়ে যাবে। If my cerebellum is not working, I will not have the idea কে এটা এখানে শেষ, আমাকে এখানে থামতে হবে। cerebellum না হলে, that is past pointing, আমি বেরিয়ে যাব এবং I will fall. Clear? So প্রত্যেকটা জিনিস for the motor system, cortex should work, corticospinal tract should work, pyramidal tract should work, extrapyramidal tract should work. Remember, pyramidal, extrapyramidal is the part of corticospinal, is the part of descending pathway, of which pyramidal is for the voluntary action, extrapyramidal is for the involuntary action. Extrapyramidal এ কে কে রয়েছে? Rubrospinal, vestibulospinal, tectospinal, reticulospinal, তার মধ্যে pontine, medullary, একটা হচ্ছে পজিটিভ, একটা হচ্ছে নেগেটিভ। মেডালারিটা ইনহিবিটরি রেসপন্স ডাউনওয়ার্ড দেয়। ওভারঅল রেসপন্স অফ আপার মোটর নিউরন অন লোয়ার মোটর নিউরন ইজ ইনহিবিটরি। সেই জন্য whenever upper motor neuron is cut, what will happen? Whenever upper motor neuron is cut, what will happen? কি হবে? টোন বেড়ে যাবে। আপার মোটর নিউরন না থাকলে কি হচ্ছে, উপরে যে ইনহিবিটরি রেসপন্স দ্যাট ইজ নট ওয়ার্কিং, সো নিচের টনিক রেসপন্সটা বেড়ে যাচ্ছে, সো ডেফিনেটলি টোনটা বেড়ে যাচ্ছে, হাত পা মুভ করাতে গিয়ে ডিফিকাল্ট হবে। এই জায়গাগুলো একটা চাই। হোয়াট ইজ ডিকর্টিকেট অ্যান্ড ডিসেরিব্রেট রিজিডিটি? পরীক্ষায় কোশ্চেন আসে, এটা আমার পার্টে ছিল না, বাট এ তো পরীক্ষায় কোশ্চেন আসে। ডিকর্টিকেট, ডিসেরিব্রেট। ডিকর্টিকেট মানে কোথায় লিশন? Just below cortex, just below cortex, rubrospinal tract is working. Rubrospinal tract is an involuntary tract that causes the flexion of the upper limb. Rubrospinal tract যদি কাজ করে, extrapyramidal tract, but decorticate হয়ে গেছে, patient এর পজিশন হবে this, বুঝতে পেরেছো? যেদিকটা ডিকর্টিকেট সেদিকে পাটা এরকম হবে, পাটা এরকম হবে। কেন? কারণ টোনটা বেড়ে যাচ্ছে, এক্সটেনশন টোন হয়ে এরকম হয়ে থাকছে। কিন্তু রুব্রোস্পাইনাল ইজ ওয়ার্কিং, সো পেশেন্টের পজিশন হচ্ছে দিস, দিস ইজ ডিকর্টিকেট রিজিডিটি। বুঝবে কর্টেক্স এর নিচে গেছে, মিড ব্রেনের নিচে যায়নি, কর্টেক্স এর নিচে গেছে, মিড ব্রেনের নিচে যায়নি। ডিকর্টিকেট, কর্টেক্স কাটা গেছে। ক্লিয়ার এভরিবডি? ডিসেরিব্রেট, ব্রেন কাটা গেছে পুরো সেরিব্রাল। তো এখানে কি হচ্ছে, সুপিরিয়র অ্যান্ড inferior colliculus এর মধ্যে দিয়ে লাইনটা কাটা গেছে। Rubrospinal is also gone. Decerebrated rubrospinal is also gone. The patient will look like this. Upper, lower, both extensor. Upper, lower, both extensor. Patient এর পজিশন হবে এই। যদি decerebrate rigidity হয়, ডিকর্টিকেট রিজিডিটিতে ফ্লেক্সর। ক্লিয়ার? স্ট্রোকের পেশেন্ট পড়ে আছে দেখতে পাবে, কারোর ক্ষেত্রে এরকম পুরোটা, কারোর ক্ষেত্রে এরকম অ্যাফেক্টেড আর্মের ক্ষেত্রে। যাদের এই পজিশন তাদের ডিকর্টিকেট আরো উপরে লিশন, যাদের এই পজিশন পুলিশম্যান টিপ হ্যান্ডের মতন অবস্থা হয়ে রয়েছে, সেটা তো আলনা নার্ভের সাথে কানেক্টেড ছিল, যাই হোক। তো এই পজিশন দুটোই, আপার এন্ড লোয়ার লিম্ব দুটোই তোমার এক্সটেন্সর হয়ে গেছে, তাদের ডিসেরিব্রেট, মানে মিড ব্রেনের মধ্যে দিয়ে কেটে বেরিয়ে গেছে, রুব্রোস্পাইনাল ট্র্যাক্ট এন্ড দ্য নিউক্লিয়াস ইজ গান। পরীক্ষায় ডিকর্টিকেট ডিসেরিব্রেট আসে, এন্ড আমাদের যে অস্পিতে পিকচার দেখিয়ে ক্যান বি আস্কড, একটা দুটো পেশেন্টে ইজি। তো এরকম ফ্লেকশন যদি আপার লিম্বে পাও, ডিকর্টিকেট, এইটা যদি পাও ডিসেরিব্রেট। ক্লিয়ার? এইটা ভীষণ ইম্পর্টেন্ট আছে। এছাড়া পরীক্ষার জন্য যেটা তোমাদেরকে ভীষণ ইম্পর্টেন্ট থাকছে হচ্ছে যে পস্টেরিয়ার ট্র্যাক্ট, অ্যাসেন্ডিং ট্র্যাক্টের মধ্যে কি কি নিয়ে যায়, কি কি সেন্সেশন নিয়ে যায়? ডর্সাল ট্র্যাক্ট, ফাইন টাচ, ভাইব্রেশন, পেন কে নিয়ে যায়, পেন, ল্যাটারাল স্পাইনোথ্যালামিক ট্র্যাক্ট। What is Brown-Séquard syndrome? হেমিসেকশন হলে কি হবে? ইপসিল্যাটারাল কি কি চলে যাবে ব্রাউন-সেকার্ডে? ফাইন টাচ ছেড়ে দাও না, ট্র্যাক্ট বলো। ব্রাউন-সেকার্ড মানে হচ্ছে হেমিসেকশন অফ দি স্পাইনাল কর্ড। তো রাইট সাইডে হেমিসেকশন হয়ে গেছে। কিভাবে হয়েছে? রাইট সাইডে একখানা লিশন আছে, রাইট সাইডে যা ট্র্যাক্ট আছে তার উপরে প্রেসার দিচ্ছে। ক্লিয়ার এভরিবডি? তাহলে রাইট সাইডে if I am having Brown-Séquard involving right side, what will be the changes? কোন tract will be involved? Ipsilateral dorsal column will be involved or not? So right side থেকে কোনো ফাইন টাচ, তারপরে তোমার স্টিরিওগনোসিস, জয়েন্ট পজিশন সেন্স কিছু থাকবে না, ভাইব্রেশন আসবে না। ঠিক আছে? Ipsilateral corticospinal tract will be affected or not? ইপসিল্যাটারাল কর্টিকোস্পাইনাল ট্র্যাক্টও ইনভলভ হবে, মানে রাইট সাইডে মোটর চলে যাবে। তোমাদের এইখানে কনফিউশন হয় যে কর্টিকোস্পাইনাল তো ক্রস করে, বাট দ্যাট ক্রসিং ইজ হ্যাপেনিং অন দি মেডালা। তো উপর থেকে প্রপার দুদিকেই আসছে, এইখান থেকে যখন রাইট সাইডে যাচ্ছে এইখানে ক্রস হয়ে যাচ্ছে, ফলে রাইট সাইড উইল নট মুভ। ব্রেন ঠিক আছে, মাই লেফট সাইড অফ কর্টেক্স ইজ সেন্ডিং সিগন্যাল and it should come to left side of cortex, signal should come to right hand. It is okay. This level it is not okay. Since it is not okay, up to this signals are coming, but beyond that signal is not coming. Clear everybody? তাহলে এই সাইডে যদি Brown-Séquard হয়, no touch is coming from here, no movement is happening here. Clear? Pain and temperature কি হবে? এই সাইড থেকে যে পেন এন্ড টেম্পারেচার হবে ওটা চেঞ্জ হয়ে যায়, ওই সাইডে চলে যাচ্ছে। সো পেন টেম্পারেচার এদিক থেকে ফিল করব, কিন্তু এই সাইড থেকে যে পেন এন্ড টেম্পারেচার সেটা যখন এর মধ্যে দিয়ে যাওয়ার চেষ্টা করছে, এখানে দ্যাট ইজ ক্রস। সো পেন টেম্পারেচার ফ্রম দিস সাইড উইল নট বি ফেল্ট। সো পেশেন্ট তোমার কাছে আসবে, এদিকে দেখছো জয়েন্ট পজিশন সেন্স অর ভাইব্রেশন ইউ কান্ট গেট, দ্য পেশেন্ট কান্ট মুভ হিজ লিম্বস, বাট তুমি একটু ডু আ পিন প্রিক, পেশেন্ট ক্যান আন্ডারস্ট্যান্ড দিস ওয়ে উইথ ইউ। আমরা দেখবো কি করে? জয়েন্ট পজিশনটা দেখতে পারি, ভাইব্রেশন দেখতে পারি। ক্যান ইউ ফিল দ্য টিউনিং ফর্ক হিয়ার? নো। ক্যান ইউ ফিল দ্য টিউনিং ফর্ক হিয়ার? ইয়েস। ক্যান ইউ মুভ দিস লিম্ব? নো। ক্যান ইউ মুভ দিস লিম্ব? ইয়েস। ক্যান ইউ ফিল দ্য পিন? ক্যান ইউ ফিল দ্য পিন? ওয়ার ইজ দ্য পিন? আন্ডারস্টুড? এইটা হবে তোমার ফিচার। তাহলে রাইট সাইড থেকে পিন প্রিক পাচ্ছে, লেফট সাইড থেকে পিন প্রিক পাচ্ছে না, কিন্তু লেফট সাইড মুভ করতে পারে, লেফট সাইডে সেন্সেশন আছে, টাচ বুঝতে পারছে, টেম্পারেচার বুঝতে পারছে না। গট মাই পয়েন্ট? তো দিস ইজ Brown-Séquard syndrome। যদি কমপ্লিট চলে যায় স্পাইনাল কর্ডটা তাহলে কি হবে? এনিথিং ডাউন গান, কমপ্লিট গেলে কি কি প্রবলেম হতে পারে? প্যারাপ্যারেসিস, প্যারাপ্লেজিয়া, কমপ্লিট লস, প্যারাপ্লেজিয়া, পার্শিয়াল উইকনেস, প্যারাপ্যারেসিস। এটাই কি হচ্ছে ব্রেনে গেলে বা Brown-Séquard-এ হেমিপ্যারেসিস, হাফ অফ বডি। পরে এটাও জানবে হেমিপ্যারেসিস তার সাথে ক্রেনিয়াল নার্ভ গেছে অপোজিট সাইডে, ব্রেন স্টেম এলিশন। হেমিপ্যারেসিস একই দিক গেছে, আরো উপরে এলিশন, ইন্টারনাল ক্যাপসুল, সাবকর্টেক্সে। ইউ উইল নো দিস লেটার। মাথায় জাস্ট দিয়ে রাখছি টু ক্রিয়েট আ কোশ্চেন, যাতে পরবর্তী ইয়ারগুলোতে গিয়ে ইউ ক্যান থিঙ্ক অ্যান্ড লোকেট। নিউরোতে পুরোটাই হচ্ছে টু লোকালাইজ এলিশন। এই তোমাদের পরীক্ষাতে পরবর্তীকালে মেডিসিনের পরীক্ষা দেওয়ার সময় টু লোকালাইজড ডেলিশন, পেশেন্টের স্ট্রোক হয়েছে, কোথায় স্ট্রোক হয়েছে, দ্যাটস দি কোশ্চেন। এইগুলোর বেসিকের উপরে বেস করে ইউ হ্যাভ টু আন্ডারস্ট্যান্ড। তো ব্রাউন সিকার্ড হলো, যদি স্পাইনাল পুরো চলে যায়, লোয়ার ডাউন কি কি চলে যাচ্ছে, সেন্সারি গান, মোটর গান, অটোনমিক গান। অটোনমিক চলে যাওয়ার জন্য দেয়ার উইল বি ভেরি, মানে নিচের পার্টে পুরো লেগ তো অনেকটা জায়গা, দ্য লোয়ার পার্ট অফ দ্য বডি তো মানে সার্ফেস এরিয়া ইফ উই থিঙ্ক অর মাস ইফ উই থিঙ্ক হিউজ এরিয়া, ভাস্কুলার এন্ডোথেলিয়াম প্রচুর রয়েছে লোয়ার পার্টে। সো ইফ উই হ্যাভ এনিথিং বিলো দ্য ওয়েস্ট, সেই জায়গাতে যদি তোমার ভেসো কনস্ট্রিকশন না হয়, হোয়াট উইল হ্যাপেন টু দি বিপি, ব্লাড প্রেশার উইল ড্রপ, হাইপোটেনশন পেশেন্টগুলোর হবে। What will happen to micturition and defecation? Problem, bladder bowel problem, either spontaneous হয়ে যাচ্ছে অথবা রিটেনশন হয়ে যাচ্ছে। মাথায় ভাবতে পারছে সব, কিন্তু রিটেনশন হয়ে যাচ্ছে, and রিটেনশন হওয়ার পরেও ফিল করতে পারছে না, because sensation is not coming down. So patient doesn't even know কে ওর কোমরের নিচে আর কোনো অর্গান রয়েছে or not, নেই। এই জিনিসটা দাঁড়ায় ইনিশিয়াল ফিল। তারপরে যখন স্লোলি স্পাইনাল শক থেকে ইউ কাম ব্যাক, দেন দেয়ার উইল বি ডিসরিফ্লেক্সিয়া। তো বেশ কিছু রিফ্লেক্স খুব এক্সাজারেটেড ওয়েতে হতে থাকে, বিকজ নো ইনহিবিটরি সিগন্যাল ইজ কামিং ফ্রম দি টপ, এভরিথিং ইজ কাট। লোকালি রিজেনারেশন হচ্ছে মানে কি, দেন ইট উইল ডিপ টেন্ডন রিফ্লেক্স স্লোলি আসছে, সুপারফিশিয়াল রিফ্লেক্স স্লোলি আসছে, আমাদের মিকচুরিশন রিফ্লেক্স, ডিফিকেশন রিফ্লেক্স এগুলো ফিরে আসছে, টু সাম এক্সটেন্ট ভেসোমোটর টোন সেটাও ফিরে আসছে, বাট দে আর কামিং ইন অ্যান এক্সাজারেটেড ফ্যাশন। তখন যেটা হয়, ইফ ইউ সাপোজ পিঞ্চ সামওয়্যার অর ইন দি মিডিয়াল পার্ট অফ দি থাই, একটা পিঞ্চ করলে দেয়ার উইল বি ওভারওয়েলমিং অ্যাক্টিভেশন অফ দি রিফ্লেক্সেস। একসাথে দেখা যাচ্ছে যে পেশেন্টের ভেসোমোটর টোন শুট আপ করছে, ডিফিকেশন মিকচুরিশন টোন শুট আপ করছে, পেন সেন্সেশন শুট আপ করছে, উই কল ইট মাস রিফ্লেক্স। মাস রিফ্লেক্সটা কি, ডিউরিং দি রিকভারি পিরিয়ড আফটার স্পাইনাল শক, even a non-noxious stimuli can lead to overwhelming activation of the reflexes. এবং তখন পেশেন্ট কি করবে, পেশেন্ট বলবে ওরে বাপরে মারাত্মক রকম অসুবিধা হচ্ছে। কি কি অসুবিধা, সিভিয়ার ডিপ টেন্ডন রিফ্লেক্স অন হয়ে যেতে পারে, there will be severe contraction of the muscle, there will be defecation, there will be involuntary micturition, plus overwhelming vasoconstriction leading to high rise of blood pressure. So mass reflex টা খুব রিস্কি, ইভেন নর্মাল টাচ থেকেও হয়ে যেতে পারে ডিউরিং দ্য শক। সেই জন্য উই হ্যাভ টু টেক কেয়ার অফ দিস পেশেন্ট ইন আ ভেরি জেন্টল ম্যানার। ক্লিয়ার? মাস রিফ্লেক্সটা কিছু না, যখন স্পাইনাল রিফ্লেক্স গুলো আবার ব্যাক করছে, কন্ট্রোল নেই তো ওই মোমেন্টে, দেয়ার ইজ নো কোঅর্ডিনেশন অ্যান্ড নো inhibitory response from the top. Therefore, there will be exaggerated and non-harmonious reflex activation, which may lead to autonomic hyperactivity, muscular hyperactivity, and excessive noxious stimuli from sensation part. Patient, it will be very dangerous and uncomfortable for the patient. ক্লিয়ার? জিনিসটা কি করে আমরা মাস রিফ্লেক্সকে অনেক সময় ইমপ্রুভ করি, পেশেন্টকে সিটিং পজিশন করে দেওয়া হয় অনেক সময়, সো দ্যাট কিছুটা ব্লাড নিচের দিকে চলে যাচ্ছে। দেয়ার আর সার্টেন পার্টিকুলার পজিশনাল চেঞ্জেস আর দেয়ার বেসিক্যালি, এগুলো পরবর্তীকালে তোমরা জানো। সো দিস ইজ অল অ্যাবাউট দি থিং। আজকের মোস্ট ইম্পর্টেন্ট পার্ট ওয়াজ দ্যাট ওয়ান, থার্ড সিক্স কানেকশন অ্যান্ড এ লিটল বিট পরীক্ষার জন্য ইউএমএন এলিমেন্ট ডিফারেন্সেস মাস্ট, পিরামিডাল এক্সট্রা পিরামিডাল ডিফারেন্সেস মাস্ট, স্পাইনাল কর্ডের ক্রস সেকশন আঁকতে পারাটা মাস্ট, ব্রাউন সিকার্ড ইম্পর্টেন্ট, কমপ্লিট ট্রানজাকশন অফ স্পাইনাল কর্ড ইম্পর্টেন্ট, রিকভারি আফটার স্পাইনাল কর্ড ইম্পর্টেন্ট। এই কটা জিনিস পরীক্ষার জন্য ভীষণ ভীষণ, এগুলো কয়েকটা বার প্র্যাকটিস করে চলে আসবে। সাইমালটেনিয়াসলি সেন্সারি ট্র্যাক্ট গুলো পরীক্ষার আগে প্র্যাকটিস করে আসবে, কোন সেন্সারি ট্র্যাক্ট পস্টেরিয়ার দিয়ে যাচ্ছে, কোনটা ল্যাটারাল দিয়ে যাচ্ছে। ট্র্যাক্ট এঁকে দিলেই আমরা কিন্তু 60-70% মার্কস দিয়ে দেবো, ইভেন ইফ ইউ রাইট নাথিং। কিন্তু তোমার পাশের লোকটা ভুল ট্র্যাক টাকছে, তুমিও ভুল ট্র্যাক টাকছো, তাহলে দুজনকেই কম দিতে হবে, দ্যাটস দ্য ডিফারেন্স। ক্লিয়ার? আর থার্ড অ্যান্ড সিক্স ভেরি ইম্পর্টেন্ট, কারণ ওই খাতাটা দেখতে গেলে থার্ড অ্যান্ড সিক্স এর কোঅর্ডিনেশনটা ভীষণ ইম্পর্টেন্ট পরীক্ষার সময়। আমাদের থার্ড অ্যান্ড সিক্সটাই আমাদেরকে বাঁচিয়ে রেখেছে, এবং ভেস্টিবুলার রিফ্লেক্সও বাঁচিয়ে রেখেছে, কারণ পিছন থেকে যখন ডাকছে কে তাকাচ্ছে পিছনের দিকে, এটা কিভাবে হচ্ছে, টেকটোস্পাইনাল অ্যান্ড ভেস্টিবুলার রিফ্লেক্স। ক্লিয়ার? তো এক্সামের জন্য এগুলো ভীষণ ইম্পর্টেন্ট। সবার থেকে বেশি এক্সামের জন্য ইম্পর্টেন্ট হচ্ছে কর্টেক্স, সেইটাকে একটু কাজ করাও। পরীক্ষাটা এসে গেল মোটামুটি, এই দিস আর দি কোশ্চেন। এর পরে পারলে দিস ইজ সেটা পরবর্তীকাল। Clear? Done. Thank you. I think this is the last one for today and for the year. Okay, good morning, everyone. So we are nearly flocking to the examination. 1 week left only, and then bingo, the big boom. Anyways, we are completing the system in the head and neck. We have covered the relevant topics related to the brain, and will be couple of topics will be covered as well. Some of the developmental topic is left or are left, will be covered accordingly. So this is one of the important topic which is given several times in exam question, formed as a long question, short questions. Even in the practical viva, we have an organ viscera related to it. We seen this particular organ and viscera been tested in a quiz in examination, and we asked the theoretical question based on this. Moreover, this particular organ is an important organ for your understanding, for your clinical life, because it's an organ for productions of the voice or noise. So whenever you're talking about this particular larynx and little bit of the trachea, we have to relate to it. We'll be talking about some salient features of it. What are the salient features we're going to talk here? Is that we are going to talk about the skeletal structure of the larynx. That means what makes this particular larynx on the bony or the cartilage contributions of it. Then we learn about those things. Then we talk about the muscles which are related to it, which is making this particular larynx to work or stabilize. These are the two things. And then we have to know the interior or the cavity of the larynx. What are the anatomical features that exist interior to the larynx, which are of course the part which is visceral concern. We can see that in our organs or the sections anatomy there as well. Then we go in the clinical part or clinical understanding on the larynx in terms of the disease understanding and what we can mess up during surgery, etc., if you are not careful about dealing these things. And larynx, by this we know that this is an organ which is producing this particular phonation or the voice. We are not going to talk about how we are making voice, how these vibrations is taking place, how these things are producing the sound or noise. Those things or physiological concern we are not going to talk. We are just going to restrict the things in anatomy and as well as the clinical anatomy. So to start with this, we have to understand this particular larynx in terms of this particular skeletal problems or skeletal structure first. And we have to know the functions of the larynx, which is one we have mentioned that it is the organ which is producing the voice. Secondly, it's a part of respiratory organ. That means it's the air which goes in and comes out through bypassing these particular tracts within this particular larynx. So it is a kind of thing which is present in both of these, the air which is related to this respiration and as well as the power of phonation or voice production. So these are the two concerns of the functions of the larynx is concerned. Now, if you go into the larynx, we have to know this particular architecture, So basic architecture of the larynx, we have to know, we have to understand. Then we can just like move through. Now this particular structure, as you are seeing here, which is placed in front of this pharynx, which is lying there. We call this area which is behind here with the pharynx. So in front of the pharynx it is placed, we call them as larynx. The part of the pharynx which is placed over here, we call them as laryngopharynx. So we can say this part of the voice box is placed in front of laryngopharynx. Is existing between this particular vertebral landmark C3 to C6. That means we have this particular vertebra mid portions of this particular neck region. We have this particular larynx placed. Now, if you look at this particular organ, the skeletal structure, it is made of some bones and cartilages which is stacked or put in top of this particular tube which is known as the trachea. So the trachea which is present below and this particular larynx which is placed over here. Now, if you see this particular architecture of the larynx, you see that this is a kind of U-shaped bone which is present on the top side. We call this hyoid bone. So this hyoid bone is not a part of larynx or voice box. It's a kind of adjuvant or contributory element, but not a part of the larynx or voice box.
So it is present on top, but we have to talk about this particular hyoid bone whenever you are regarding the larynx. Now, after this, we have this particular piece of cartilage. We call this as thyroid cartilage, which is present over here. Between this particular hyoid bone on top and this particular thyroid, we have a presence of a membrane, which is a part of the extended larynx, we can say. This particular membrane, or kind of like a sheath-like structure, which is extending between the hyoid bone and this thyroid cartilage, we call them as thyrohyoid membrane. So this particular thyrohyoid membrane is a point of concern for us. We will be learning about this thing, thyrohyoid membrane. And you can see, if you just like have a good eye, you can see there is a hole present on the lateral side. It's tiny hole on the superior side. This tiny hole is for piercing some neurovascular structure, which is basically entering into the larynx. We'll be coming across. Now, after this particular middle cartilage, which is the widest cartilage in the larynx, we have a bottom cartilage which is lying immediately below. We call this cartilage as cricoid. These particular structures are visible and palpable. We have this particular thyroid cartilage midline. We can feel that. Now, this particular point where you're feeling this meeting point of the thyroid cartilage, we call them as lamina of the thyroid, which is meeting in the central position. We call them as Adam's apple, which is projected and pronounced in case of these male subjects, which is because having more acute angle, which is present. Now, if you roll down the finger from this thyroid cartilage, then you bump into a midline bone, which is lying immediate below this thyroid. That is a cricoid. And that particular cricoid in the front side, which is lying below, has a nodule. So that particular nodule can be felt. So we can feel that. Now, why we should be doing this? Because this is a kind of surface marking important for us. We'll take you there why it is important. So this particular thyroid, below here we have this particular cricoid. So just like a thyroid and a hyoid, in between we have a membrane existing. Between the thyroid and cricoid, we have another membrane existing there. We call them as cricothyroid membrane. So these two membranes are of concern. We'll be talking about the clinical aspects of these things. So this is about this particular thyroid in your gross, as you see from the front view. We'll be seeing that on the flip side, back side, front side in the different views of this larynx. Now, before we move further, we see that the cavity of the thyroid, which is present over here. So which goes through here, the air. As you can see, this arrow is passed through here. That means this air which transmits through here goes to trachea, from trachea to lungs, and it comes out in the through same way. Now this particular air which is getting in through the hyoid bone deep to here, below there, and reaching to this particular larynx, at this particular point, we have an existence of another thyroid cartilage. We call them as epiglottis, which is not visible here. We'll project in another picture which is visible. Now, this particular epiglottis, which is another cartilage or a skeletal structure of the larynx, which is present. Now, that particular element which is present, which is the doorway of this interior of the larynx, we call them as inlet of the larynx. So, we are familiar with the word inlet, like pelvic inlet, right? So, we have to know that what do you mean by the inlet and what are the boundaries of it, because the exam asks about the boundaries of the inlet. And there is a reason for it, because we have to introduce some procedure to the larynx, then you have to know what are the boundaries, or else you will be just like bumping in them and hurting them. So you have to know that part. So we are seeing this particular skeletal of the larynx. We learn about a couple of the cartilage, hyoid bone, which is not a part of this larynx itself, but it is an important. Between the hyoid and thyroid, we have a membrane existing. We call them as thyrohyoid membrane, which has got like a hole, which is a point of concern on the lateral side. We'll be telling you why shortly, this particular hole. Then we have this particular thyroid cartilage. Below there, we have a cricoid with a nodule in the front. In between this thyroid and the cricoid, we have this particular membrane. We call them as cricothyroid membrane. That is very, very important ligament to talk about. Now, we are moving from here and taking you to these particular parts of the thyroid, of the skeletal structures of the thyroid. So this is what we see that, and if you just like make a cross section, we can see this particular view of the larynx, pharynx, thyroid, and everything in the soft tissue structure together in this particular sagittal section, which is familiar with us, including the oral cavity. Now we are moving to this particular skeletal framework of this particular larynx. As we are mentioning, this particular larynx are made of piece of cartilages which are joined together, making this particular voice box or larynx. There are some cartilages which are paired and there are some cartilages which are unpaired. We have to articulate them, we have to write the names because these are the exam question. Name the cartilages or skeletal elements which is making the thyroid cartilage. You have to mention about this larynx which is making here. So we have this paired cartilage which is starting with the thyroid. Then we have regarded another cartilage which is known as cricoid. We learn about it. And then we have the epiglottis. Now, epiglottis, we haven't seen that in a previous picture. Now it is visible in this particular larynx which is present here. We can see this particular thing which is coming out as a tongue-shaped or lip-shaped structure popping up from this top of this hyoid bone. And this particular thing which you're seeing on the posterior view, this is the anterior view, this is the posterior view, and this is a side view. That's what you're seeing here. You see this particular broad cartilage singly placed in the midline. This is epiglottis. It has a look like lip, which is a broad expanded upper part, and the tapered lower end, which is anchored to the interior of the larynx skeleton or the larynx voice box. So these are the paired cartilage. These are the important and a robust of them or largest of them. There are particular cartilage which is present in here. They are not that great, but they are paired. So they are tiny cartilages, those who are paired cartilage. We call them as arytenoid. So where we can find arytenoid, this is a very tiny cartilage present here. This is the back side of the cricoid we are seeing here, and it is projected on top of this particular cricoid. We see a triangular shaped cartilage. We call this triangular shaped cartilage as arytenoid. So this cartilage is present on the top of this. Then we have this particular two cartilages which is barely visible. We call them as corniculate, by the corn. So we call this corniculate, it looks like a corn, very tiny corn. That's why we call them as corniculate. It sits on top of this particular arytenoid, very tiny piece of cartilage, just like dots. It looks like this. So corniculate cartilage, and then within this particular fold of the mucosa, which is extending between the epiglottis to this particular arytenoid, we have a fold. Within this particular fold, we have another very tiny cartilage there. We call them as cuneiform. So we have to know these names, how they are placed. We have to talk a little bit about both of these particular cartilages, how they look like, because those things will be very short. I'll be keeping this thing short. So let's talk about the thyroid cartilage. This is a midline, broadest of all. Looks like a butterfly which is having got this particular projected part. We call them as lamina. Then you have the notch, which is known as superior notch. You have the notch below, inferior notch. It is a projected on the back side. We call them as horns or kind of like a projected part of this particular thyroid, which is going up here. You can see that this particular call them as horns of the thyroid, which is projected upwards. We call them as superior horn. Projected below, we have this inferior horn, and meeting in the midline, these two laminas, which is making a prominence. We call them as laryngeal prominence, or in layman's word, we call them as Adam's apple, which is a very popular common term. So this laryngeal prominence is palpable, visible structure which you can see, and you must identify this thing, which is the laryngeal cartilage is concerned. Now, other than this particular cartilage have got no other importance. Between this particular thyroid and hyoid, we have an existence of the membrane. We mentioned about it. Those things are important. That's what you're coming here. This is the thyroid cartilage. This is a side view of the larynx and the trachea we are seeing. You're looking on the individual from the sides. Now, between this bone is a hyoid bone and this is thyroid bone. So, between them we have a membrane. We call them as thyrohyoid membrane. In the thyroid membrane, on the lateral extremities, you see there is a hole there which is circled over here. This particular hole is pierced by a neurovascular structure. A nerve gets inside the larynx, a blood vessel which goes inside the larynx, which is piercing through. That's why this is important, and we ask this question in examination. Guy giving either tagging this as an exam question, what are the structure, identifying them, and functions of it. The blood vessel which is piercing here, getting inside, supplying the larynx. We call them as superior laryngeal blood vessels or superior laryngeal vessels. Now you can see, piercing this membrane, if a nerve goes inside and supplies the larynx, we will be calling some nerve which is going internal. So we call them as internal laryngeal nerve, which is a branch of superior laryngeal nerve. Superior laryngeal nerve has got two branches. One is internal, other is external. This internal branch piercing through here, getting inside, supplies the inside of this mucosa of the larynx in the upper half. We'll be talking about this later in detail. So this particular thing again is exam important. We see this particular things is kept coming up in examination. Why? Because if you are doing thyroid surgeries, these things comes across. We have to take care of these particular structures as well with care, or else we'll be damaging these particular structures in this region. If you're doing any surgery in the upper part of the neck region, lymph node reductions, or if you're doing any maneuver related to the hyoid bone, this particular structure comes over here, and you have to be mindful, or else we'll be having trouble over there. Now, this thyroid membrane, the lateral extreme, we call them as lateral thyroid ligament. It's nothing but the same thyroid ligament, the lateral part, and the midline part, we call them as median thyroid ligament. If you cannot remember this lateral thyroid ligament, medial thyroid ligament, just don't do that. Just remember this particular thyroid membrane, which is present between them, and it is pierced by this particular structure. That's it. Now, coming from these particular muscles which are related to this particular thyroid gland or thyroid cartilage, present in front, present in back. We have seen this particular muscle which is present in front of this particular trachea, which is present in the muscular triangle, which is the strap muscle, which is present on the front side. We know the strap muscles. Everything starts with thyroid, etc., etc. Those are the strap muscles which looks like a ribbon. We call them as flat strap structure, which is present in the front side. So between this thyroid and hyoid, if it is muscle is present, we call them as thyrohyoid. If the muscle is coming from the sternum and ending in the thyroid, we call them as sternothyroid. If it is a muscle between this particular thyroid and cricoid existing, we call them as cricothyroid, etc., etc. So these are the anterior muscle present to the thyroid cartilage. There are posterior side muscles there. The structure lying on the back side of the thyroid is the pharynx. So muscles of the pharynx will be present on the back side of this. What are the muscles which is present on the back side? Like constrictor muscles, which is present on behind or posterior to this particular thyroid gland. So this stylopharyngeus, palatopharyngeus, and the constrictor muscle which is present on here, they are parts of this particular pharynx, and they are present on the back side or posterior of this particular thyroid cartilage. Why I'm elaborating the thyroid? Because the thyroid itself may be given as a part of the short note. Just like elaborate the names of this particular cartilages present or skeletal formations of this particular larynx, and elaborate on thyroid cartilage, the parts and the components and the muscles related to it. So you can just like mention about these are the parts, these are the membranes which is related to the thyroid gland, thyroid cartilage, and the muscles which is related to it. That's how you can build on it. So not anything and everything you can prepare and get ready for the examination before coming in. Sometimes you have to make up during the examination through the knowledge whatever you have. From thyroid, we have another unpaired cartilage which is known as cricoid. This particular cricoid, anteriorly it is having a ring. It is circular and it has a nodule in the front side. If you take it on the back side, it is projected upside. We call them as a lamina of the cricoid. So this particular cricoid which is lying on the back side, you can see that this is a cricoid anterior side, and this particular cricoid, this is a posterior view. So it is projected on the back side. This particular projected on the back side, we call them as lamina of the cricoid. Anteriorly, we call them as the ring of the cricoid. So this particular cricoid and the thyroid, in between them, we have a membrane existing. We call them as cricothyroid membrane. Now, this particular cricothyroid membrane, as you can see, this particular thing which is present over here, this is very important landmark. Why it is important? That's why we keep on telling you, identify this thyroid cartilage in you or on your patients, and identify the cricoid. This landmark is important. This is a life-saving landmark. So between this particular cricoid and on top we have the thyroid. So between this we have the membrane. We call them as cricothyroid membrane. Now this particular cricothyroid membrane is avascular. That means we do not have a blood vessel present on it. So if you have to quickly, emergently get inside the airway tube for any reason, no scalpel, nothing is required to get in here. With the bare pen or pencil, we can get in here and save a patient's life. So that's why this particular landmark, we call them as cricothyroid membrane. Piercing this cricothyroid membrane is a lifesaver condition. It's a condition where you can save the patient's life. So these two landmarks saves a lot for the patients. We'll talk about the clinical scenarios when you're talking about the clinical parts. So cricothyroid membrane, which is known as median cricothyroid membrane, which is a midline part, which is also really avascular, and we must know this landmark. So from this particular cricoid, we are just like going to the cartilage, which is another unpaired, which is known as epiglottis. It looks like a structure which is known as the lip structure. It is a broad base and a tapered bottom end, and this particular thing which is like a present in oblique fashion. You can see this particular area. This is the anterior view, this is the posterior view. This is the thyroid cartilage, this is the backside cricoid and the arytenoid on top. So this particular cartilage which you're seeing here projected like tongue and popping up, if you just like open your mouth and extend the tongue out widely, you can see this particular up end of this epiglottis visible, white piece of cartilage visible. If you throw light, if you see under light on through the mouth, you can see this particular cartilage every time. So this particular upper part of the epiglottis is visible and it is covered by the mucus. It's made of elastic cartilage and it has upper part, bottom part and the body which is anchored. And this particular area of this particular epiglottis is guarding an opening in between them. So this is the opening which you're seeing here, extending in between this thyroid cartilage and over here. So this opening I am referring here, we call them as inlet of larynx. So this inlet of the larynx matters. Why? We have to get inside the larynx to do any procedure, whatever thing. Say for example, you have a tumor in the vocal cord. So we have to go through the mouth, get inside through this inlet of the larynx, do the surgery and get out. So you have to come carefully through the inlet. If you do not know this particular inlet, the boundaries of it, we can mess up. So this particular epiglottis is guarding this inlet in this region which is related to it. We'll be coming to the inlet once again. We will elaborating this inlet part. Now coming from this part of this inlet, that it has got different parts, broad upper end, tapered lower end, and in between this he has a body and it has a ligament which is anchoring to it. We call them as hyoepiglottic ligament, which is anchoring the hyoid bone with the epiglottis. We have another tiny ligament holding this epiglottis with the thyroid. We call them as thyroepiglottic ligament, which is holding this particular thing upright like this. It is holding in these particular positions. Just like a leaning tower of Pisa, it is leaning over here and held by some ligaments in this particular positions which is lying there. Now, contrary to this, we have an understanding this particular lead-like structure maybe look like lead and maybe dropping. No, it is not. So this particular epiglottis do not move when you swallow or doesn't lead, this particular lead closes. So no matter what, this particular lead never drops down, closes the inlet and again pop up open. These things do not happen. It apparently looks like a lead and it is going to close the inlet, and once it is something is done, then it is opening up. It is not happening. So there is no movement whatsoever happens over here with these movements of epiglottis during swallowing or during anything. Alright, so I'll be coming again. So this particular element which you have understood, the positions of the epiglottis, why this epiglottis is kept in like oblique positions, leaning position, and how this particular ligament is holding these things up and this restricting any movement whatsoever which is present in the epiglottis. So get these things clear over here. Now, coming from this, another piece of cartilage which is paired piece of cartilage. This thing will be just like a discussing. Now, this particular cartilage which looks like a pyramid sitting on top of cricoid, we call them as arytenoid. This triangular shaped cartilage, we call them as arytenoid. This had three projections. One is this side, we call them as vocal process. This is on the back side, we call them a muscular process, and the top side, which is a bony process. So on the top side of the arytenoid, we have a bone which is sitting in here, which looks like a corn. We call them as corniculate. Onto this vocal process, we have a ligament attached. We call them as vocal fold or vocal ligament. On the back side, we have a muscle attached to that. We call them as posterior arytenoid, yes, lateral arytenoid. So based on this attachment which this particular arytenoid has, this particular thing is given different process names. So apex, and here has a process which is vocal process, muscular process. These things, what are these things? We have to know a little bit about. So I will be emphasizing on knowing on this particular paired cartilage with little detail about apex and vocal process and muscular process, because these things will be building on the next part about learning about this vocal ligament and etc. etc. So taking from here, we are going into this particular other cartilage. We call them as arytenoid. Doesn't have any importance over here. So which is lying on top of this particular arytenoid. We have this particular corniculate which is sitting on here, tiny cartilage, corniculate, and you can see this between this epiglottis and this particular arytenoid. We have a fold existing. This particular fold where I'm rolling this laser over here, we call them as aryepiglottic fold. This is also known as aryepiglottic ligament. So this arytenoid to this epiglottic cartilage, we have a mucosal fold which is coming on arching like this. So this particular arching cartilage, arching fold, we call them as aryepiglottic fold. Within this aryepiglottic fold, we have two other paired cartilage placed. One is corniculate, other is cuneiform. So we do not have to know detail about them. So just like a bypass them, just know the names of them, and if you can remember the positions, they are placed on the mucosal fold, which is known as arytenoid to epiglottis, aryepiglottic fold or aryepiglottic ligament. That's it. So again, we just summarize these things once again. We have the thyroid cartilage, which is having lamina, had got projections, and this particular thyroid cartilage anteriorly have got some muscles, posteriorly have some muscles. Then we have the cricoid, this particular cricoid which has got a circular nodular part which is present in the front, and posteriorly it has lamina. Then we have this epiglottis which looks like a leaf, and it is held in an oblique position, tagged by some kind of ligaments by hyoid and this thyroid, and placed in this region, guarding that particular opening of the larynx inlet, which is known as the epiglottic guarding the inlets of the larynx. Then we have this particular paired cartilage. Of the three paired cartilage, we emphasize only one, which is known as arytenoid, which has got 3 points to note. It has an apex. On top of apex, we have a paired cartilage placed. We call them as corniculate. It has a process which is known as vocal process and a muscular process. Based on vocal cord and the muscles attached to it, we name them. And then we have the other two paired, corniculate and a cuneiform. They are present on the folds between this arytenoid and this particular epiglottis. We call them as aryepiglottic fold. They are placed on that. And then that's all about them. So this is about the skeletal element that is important for us. That is important till now. Then we are moving to this particular element, which is again an exam question. So apart from this particular skeletal element, we see the questions they are asking about is the ligaments and this particular elements which is known as membranes, which are related to the thyroid, larynx or voice box. So a couple of ligaments we are familiar with, which are existing on here. We can name them. We have already learned between them. So between the thyroid and the hyoid, we have this thyrohyoid. Between the cricoid and the thyroid, we have the cricothyroid, which is existing in this particular element on the ligament is concerned. And we know about this particular thing, what is lateral and medial, and the cricothyroid ligament which is present here. This much we know. Now we are going to build a little bit more about this particular ligaments and the membranes. There are some ligaments and the membranes which are present below this particular mucus. We call them as submucosal membranes. Now these submucosal membranes are important. We are going to talk about that, those submucosal membranes. You will learn about why these submucosal membranes are important and what are the modifications of the submucosal membrane which makes this particular vocal cord and the vestibular cords. That's what we are bringing in here. So from here we are going to talk about this particular different ligaments which is related to it. So these two ligaments which are of concern, and other ligaments we mentioned about between this particular epiglottis and this particular hyoepiglottic, thyroepiglottic ligament. You can remember them, you can forget about them, but you cannot forget about this particular membrane or ligament which is between this thyroid and the hyoid, and thyroid and the cricoid. These two names you must carry with you for the examination. Next, we are building on this particular submucosal remnants of this. We are familiar with this hyoepiglottic and the thyroepiglottic ligament folds we mentioned about. If you can remember them, it's fine. If you do not, just don't bother. Then we are going to talk about something which is really important. We call them a submucosal element. Submucosal element which is related to it. So we have seen this particular larynx which is covered by a mucus, which is the respiratory mucus. If you strip off the respiratory mucosa, we are going to find some soft tissue structures. That means we are going to see some fibrous element lying deep to this mucous element. So there are two divisions of these submucosal membranes which is existing. So these two we must know, must know, and these are exam questions. Now there are two ligaments which is present below the mucus which are basically making some modification and forming the important structures of the larynx. One of them we call them as quadrangular ligament, and other one we call them as cricovocal ligament or cricovocal membrane. So these things you must pay attention and learn it, what you are seeing here. So we drop down to the picture, which is schematic at the bottom side. We figure it out, and that makes this particular thing easy for us. So we just look at this. So this is the anterior view, and this is the posterior side. This is the superior side, this is the bottom side. This is epiglottis, which is present on the top side. So you see that between this epiglottis and the back side of this particular projected cartilage, which is present, we call them as triangular shaped or pyramidal shaped cartilage, we call them as arytenoid. So between this particular arytenoid and the epiglottis, there is an existence of submucosal membrane, which is extending from here, epiglottis, to this particular arytenoid. We call them as aryepiglottic fold. So this particular aryepiglottic fold, which is extending on this region over here, yes, you can see that. Now we see that this particular cartilage, which is thyroid cartilage, and from the backdrop of the thyroid cartilage, that means inner side of the thyroid cartilage, there is a membrane which is the same one, which is a quadrangular membrane extending from here to this particular arytenoid cartilage. So we have this particular shaped curtain-like structure which is present on the interior of the larynx. We call this membrane as quadrangular membrane, which is extending above from the epiglottis to this particular arytenoid. From anterior to posterior, it's extending between the thyroid cartilage to this arytenoid. So these are the two limits, above and the below, this particular membrane has. Now this particular aryepiglottic fold, into this aryepiglottic fold, there are other paired cartilage are there, corniform and cuneiculate. They are placed in here. These are the two pieces of cartilage present on here. So this particular quadrangular membrane has got this upper end which is existing on between here, making the fold, we call them as aryepiglottic fold, holding these two pieces of cartilage. Now you will go down the lower limit of this quadrangular membrane, which is extending between the thyroid cartilage to this particular vocal process of this particular arytenoid cartilage. So this lower margin, which is free, and this lower margin is made over here, prominent over here. So this free lower margin of this quadrangular membrane, we call them as vestibular fold. So this particular vestibular fold is wrapped by mucous membrane. That particular vestibular fold is visible in a living patient or in a cadavers or in a specimen. So who makes this particular vestibular ligament? That's a point of concern. The lower free margin of the quadrangular ligament, which is extending between the thyroid cartilage to this arytenoid cartilage on the front to back. So this piece of information is important. You have to know this, you have to draw this and explain this about the vestibular fold, who makes this vestibular fold over here. And this particular thing which is hanging over here, it's a string-like structure that looks like a ligament. We call them as vestibular ligament. And if it is wrapped around by the mucus, we call them as vestibular fold. Vestibular fold is a living condition. If you strip off the mucosa, then you get this particular ligament visible. Alright, so this is about this particular element. We call them as quadrangular ligament. Very difficult to comprehend by going and learning through the books, reading them and understanding the idea about this ligament or submucosal thing. Again, if you remove the mucosa, you get this particular submucosal element. This submucosal element have got two membranes. One in over here, one is below. The top one we call them as quadrangular. It is extending above and below by these two extremes we have mentioned. Now out of this quadrangular ligament, the upper end which is lying over here, has got a name. We call them as aryepiglottic fold, which holds this particular tiny paired cartilage. We call them as corniculate and cuneiform. And then we have this particular lower free margin extending between front to back, which is known as the ligament, as vestibular ligament. These things, once it gets wrapped by this mucous element, we call them as vestibular fold. This is one part. Now, how does it look like? This is the thing which you're seeing here. This is the back side of this individual. This is the trachea. This is things which is opened over here, and you're seeing the larynx from the posterior side. This is the epiglottis, and this is the cricoid cartilage. On top of the cricoid cartilage, we have this arytenoid. So between this particular epiglottis and this particular cricoid, we have this aryepiglottic fold. So this is the upper margin of the quadrangular ligament upper margin, and lower free margin which is hanging down, not visible, which is extending from the thyroid to this particular vocal process of this arytenoid, which is making this particular vestibular fold, which is present inside of the cavity of the larynx. So this is how it looks like. This is how it is oriented. Now let's take it to this particular lower membrane. We call them as cricovocal membrane, another submucosal fold. You can see that how it is extending. It is extending on the front side and the back side between this thyroid cartilage and the same arytenoid, and the lower part is extending on this particular cricoid cartilage, which is dropping over here. So this particular element, which is known as the cricovocal ligament or cricovocal membrane, you see that extending between this particular arytenoid thyroid front to back superiorly, and inferiorly it is dropping down to this particular cricoid and making this. Now this superior margin, superior free margin of this particular cricovocal membrane, we call them as conus elasticus. So this particular element, as we are seeing here, cricovocal membrane, which is the upper free part of the cricovocal membrane, is also known as conus elasticus. This conus elasticus makes the another ligament, we call them as vocal ligament. So there are two ligaments which is existing in here. One is vestibular ligament, which is present on top, and one is below, which is a vocal ligament, which is the voice box is producing with the noise and voice, whatever you're making. So these are the two submucosal elements which you're seeing here. And this is about this particular fold that we are referring here. So between these particular elements which you're seeing here, when it is wrapped around by covered by this particular mucosal, we call them as folds. The folds are visible in a living condition or in cadavers. Once you strip off everything, take out the skeletal element, you can see this ligament, how they are extending. So vestibular fold and the vocal folds, they are basically wrapped around this particular cricovocal membrane superior part or quadrant ligament free part. So this vocal ligament and the vestibular ligament, they are kind of the important landmarks that you have to know. This vocal ligament, vestibular fold, vestibular ligament, they are also a part of short note that you have to prepare as well, along with this particular ligaments and everything. So this is about this ligaments and how this particular thing looks like. Now we have a picture about this particular vestibular fold, vocal fold. How do they look like when you see them? So this is how this particular thing, cross-section structure, which is coronal section, looks like. So this is the epiglottis, the cavity of the larynx, which you're seeing here. We see a fold on top here. This is the vestibular fold, also known as false vocal cord. The next projections which you're seeing here is a true vocal fold or true vocal cord, which is actually the vocal cord, which is having a muscle present in here, which is known as vocalis, which is along this particular vocal ligament, which is running across, which is nothing but the conus elasticus or free margin of the cricovocal ligament. So this is how this particular false vocal cord and the true vocal cord are placed and how they are present over there. And this particular larynx and voice box comes over here. This is the cavity of the larynx, which you're seeing here, down here, which is opening into the cavity of the trachea. That's how it is going down. So these particular elements, which is kind of important. Next brings us this particular thing, we call them as the rima glottidis. The space between these particular folds of this particular mucosa, between this particular vocal cord, we call them as rima glottidis. That means it is a space, we call them as between this particular vestibular fold and vocal fold, which is existing. The space which is existing between this particular false vocal cord, we call them as rima vestibuli. The space between this particular true vocal cord, we call them as rima glottidis. Now this rima glottidis, if you're seeing from top, how does it look like? So you are just like getting into the larynx, seeing that how this particular space look like. This is the normal positions of this particular rima glottidis. You see this particular space, this is made by this particular vocal fold or vocal cord. So this is the space, how it looks like. The anterior part, which is tapered, and the posterior part, which is quadrangular. So anteriorly the space, which is triangular in shape. Posteriorly, this particular space is quadrangular. Now, if I project it in the next picture, this thing makes more comprehensive to understand. So this is the vocal cord you are seeing from above. So this is our normal vocal cord. How does it look like? And the red area, we are talking about the space in between the vocal cord. So where is the vocal cord? This particular white structure is the vocal cord. This blue one, the soft tissue structure, the mucosal folds, etc., etc. So this red one, what you are seeing here, the space we call here, between these vocal cords, This space between the vocal cords, we call them as a rima glottidis. Now, this is a normal rima glottidis. Now, what you are taking here, normal breathing, you are taking. So, the normal positions of this vocal cord is like this. So, this particular thing, which is kind of triangular in the front and quadrangular on the back side. So, these normal positions of this particular rima glottidis, we call them as narrow and wedge-shaped. Now, compared from here, when you are breathing heavily, so this particular vocal cord or vocal fold wides open and opens up more. You can see this particular wedge-shaped structure becomes quadrangular. So this forced inspiration, it becomes trapezoid shaped. This is how it is going there. When you are talking like whispering, which you are doing right now, this is how it is going on. The whispering means, that means the vocal cord, which is on the right side and left side, are opposed to each other and hardly have any gap in there. We do not want to leak any air through here so that this particular vocal cord can vibrate very gently and produce the sound. When you are just talking, just like what I am doing right now, my vocal cord is in a paramedian position. That means very little slit is there, where I am allowing or disallowing a measured amount of the air coming from the larynx and the lungs to go and vibrate this particular voice box. So that this narrow air is vibrating the vocal cord and producing the sound which I am making. So this is the different positions of the rima glottidis. So you have to know what do you mean by the rima glottidis. So define rima glottidis. It's a space between the vocal cords. How does the space normally look like? It's a triangular or anterior triangular, posterior wedge-shaped, or we call them as narrow wedge-shaped structure. This is a normal breathing. How does it look like? You have to give a picture or schematic picture like this one, which is present in here. So this particular position is a normal breathing position, which is normal position like what you have. Now, the shape changes with the rima glottidis in different positions. When you are breathing heavy, it is wide open. It is become trapezoid. When you are whispering, it is narrow and super narrow. When you are talking, it is having a paramedian position. Very thin little slit air is present passing through it, which is known as the phonation point. So this particular position of the vocal cords or the vocal folds are kept in positions by the movements of the muscles which is present inside the larynx. So how this muscle of the larynx is holding these things, that's what we are going into it. So this is about the rima glottidis. This again is a short note about what is a rima glottidis, short note about rima glottidis. That means you have to define rima glottidis. What is rima glottidis? You have to mention who makes this rima glottidis, and then what are the normal positions and abnormal positions or different varied positions of the rima glottidis, etc., etc. So those things are again very important areas that you must come through to understand. So, once we have learned through the skeletal element of the larynx, we have to go inside the cavity of the larynx. So what sits in the cavity of the larynx, that again is an exam question. So every point or every corner of the larynx is your exam question. So the opening of the larynx, we call them as a laryngeal inlet. That means through which the larynx starts or ends. So larynx opens here in the level of the epiglottis region over here on this region over there and extends up to this particular first tracheal ring or the bottom end or lower end of the cricoid cartilage. So this far this larynx is extending. So if you split open the larynx, open and see the cavity of the larynx, this cavity of the larynx can be divided off 3 segments. So upper segment, middle segment and the lower segment. So we take the lower segment first, that's the easy thing. So for the understanding the lower segments, we have to identify these two. So these are the 2 folds we are referring. One is above, one is below. How do you know this is above? Because epiglottis is in above side. So this is the above fold, that is the vestibular or false vocal fold. This is the real vocal fold, holds the muscle vocalis. So this lower fold, which is known as the true vocal cord or vocal fold, which is present in here. So between this particular layer, which is layer present over here, between the true vocal fold and the cricoid cartilage, this space, we call them as infraglottic cavity or subglottic cavity. Now, the space which is lying between this particular false vocal fold and the true vocal fold, this space we call them as laryngeal vestibule, also known as, this part is known as laryngeal cavity, also known as the sinus of the larynx. Now you see the sinus of the larynx has a lateral projection which moves up over here as superiorly to some extent. We call them as laryngeal saccule, which is extending up here. Now this particular laryngeal saccule is a point of very important thing. Why this is point of very important thing? This can project up, and this laryngeal saccule can just bump up and can create a pouch there. We call them as laryngeal pouch. This laryngeal pouch have got many famous or infamous stories about. We are not going to talk about it right now, but this is about this laryngeal saccule, and the dilatations of the saccule creates a pouch. We call them as laryngeal pouch. So we have to know this particular space. We call them as sinus of the larynx, also known as ventricle of the larynx. Now, the space between this laryngeal inlet to this particular upper border of this false vocal cord, we call them as laryngeal vestibule or supraglottic part. So in a surgical part, to understand it easy, we divide it into 3 zones. Zone 1, Zone 2, Zone 3. Zone 1, we call them as supraglottic space, which is above the vocal fold till this particular cavity, which is opens up to this particular space, which is in purple shape, which is, you call them as the laryngeal inlet. Then we have the green one, the small part. We call them as transglottic space between the false cord and the true cord of the vocal cord, which has a lateral projections, which is known as saccules. We call them as ventricles of the vocal folds, which is present in here. We have tons of lymph nodes, tons of mucus secreting glands, which is present over here, moisturizing this particular vestibular gland, vestibular and vocal folds over there present in here. Then we have the pink shadow, which is the infraglottic or subglottic region, which is this region below this true vocal cord till this lower border of the cricoid cartilage. So this is the space of the cavity of the larynx is split. So we have to know about this particular spaces and the specific regions of the space. What do you mean by this particular laryngeal vestibule, the middle part of the laryngeal cavity or the laryngeal ventricle and the laryngeal saccules, and the clinical part of related to it and infraglottic cavity, etc., etc. So this particular saccule and laryngeal ventricle, you must have a clear idea about. This particular lateral space from this particular region between true cord and the false cord, we call them as laryngeal ventricle. Now this upward extension of the ventricle, just like auricle, it bumps up or moves up over here in this region, we call them as laryngeal saccule. This laryngeal saccule can encroach to this piriform fossa over this region, can grow big and create a saccule or enlarged part. We call them as laryngeal pouch. So this anatomical explanation with a schematic picture you have to prepare for exam. This is what we talk about. The opening of the larynx. We call them as laryngeal inlet. Now you have to know the boundaries of the laryngeal inlet, anteriorly, posteriorly, and on the sides. You see this particular picture, which is basically self-explanatory to understand this inlet of the larynx. This is the inlet of the larynx which you're seeing here. That means this is how the air goes in, and you can see this particular fold which is present over here. So this particular fold on top, which is the vestibular fold, and below here, which is having a white nature. This white thing which you're seeing here is the true vocal cord or true vocal fold. The vestibular fold, vocal fold, which is visible, and this region, the cavity opens here through the space. We call them as laryngeal inlet. Now, boundaries of the laryngeal inlet, anteriorly made by this epiglottis, posteriorly by this arytenoid and interarytenoid fold, and laterally by this fold which is extending between the particular arytenoid. We call them as aryepiglottic fold. So this particular boundary of the laryngeal inlet should be included whenever you are talking about interior of the larynx. So boundaries of the larynx could be itself in exam part, like describe or write down the boundaries of the laryngeal inlet, which could be exam 2 marks question, or it could be a question which is asking about, discuss about the laryngeal inlet. So whenever you're talking about the laryngeal inlet, you must know or define it where the larynx starts and where do the larynx end, and the opening which is present in the opening part or above, which is known as the laryngeal inlet. And if you mention the laryngeal inlet, you have to mention about the laryngeal inlet boundaries on that regard to this anterior, posterior and lateral. So those things you have to mention out here regard to this particular inlets of the larynx and the boundaries of it. So this is the complex thing that you have learned. Now let's move into the easier thing about this larynx, rather more difficult, right? So this is what we have learned about this larynx, and this is, we are moving into the larynx as musculature of larynx. Again, it could be a separate question as well, the muscles of the larynx. Now whenever you are going to mention the muscles of the larynx, we readily jumped into the muscles of the larynx, which is basically controlling the voice or length of the vocal cord. And we often forget, or 90% time we forget about this muscle. We call them as muscles of the larynx, as extrinsic muscles of the larynx. So whenever you are addressing the musculature of the larynx, which could be an exam 5-mark question, you have to make it 2 marks over there. One is external musculature, internal musculature. That means extrinsic muscles of the larynx, intrinsic muscles of the larynx. Extrinsic muscles of the larynx can be divided of 2 parts, elevator and depressors of the larynx. That means some of the muscles jacks up the larynx, some of them jacks down, moves up and down the larynx. Larynx moves up down when you swallow, don't it? So when you swallow, deglute, it moves up. So these are the muscles which is moving up, are elevators. Who are the muscle elevating the muscles? Those the muscles which are present on above larynx. Who is above the larynx can pull up. So what are the muscles present above the larynx? The muscles which is present in the neck region, digastric muscles, mylohyoid muscles. So those are the muscles which is present on there. Stylohyoid, digastric, mylohyoid, geniohyoid, stylopharyngeal, etc., etc. So pharyngeal muscles and this muscles which is present on the front side, front and back muscle which is present in front and back of the thyroid muscle. We mentioned at the beginning of this, they are known as elevators of it. The next group, depressor. That means the muscle which is jacking down. All the muscles which are below this muscle or below this larynx will be pulling it down. Which are the muscles below the larynx? The subhyoid muscle. What are the subhyoid muscles? The strap muscle. These are the 4 strap muscles. Sternohyoid, thyroid, omohyoid and the thyrohyoid. They are pulling this thyroid down. Elevations and the depressions of the larynx, they are known as extrinsic muscles of the larynx. So this is about the beginning thing. 2.5 marks of 5-mark question over there. So if you miss it, you are not getting the 2.5 marks of that. So then comes into the all important muscle. We call them as intrinsic muscles of the larynx. Then comes the story about the intrinsic muscles of the larynx. So there are muscle groups of the larynx which is present over here. Let's make these things easy for you to understand at the beginning. Then you can just like absorb more. So these are the intrinsic muscles of the larynx which are present. We call them as cricothyroid, thyroarytenoid, posterior cricoarytenoid, lateral cricoarytenoid, and this transverse obliquus and the vocalis. So you have to know the names of them. Like if you know this particular muscle, cricoarytenoid, posterior and lateral. So lateral and posterior cricoarytenoid. If you know this particular arytenoid muscle or arytenoideus muscle, there are 2 of them, transverse and oblique arytenoideus muscle. And then we have this particular cricothyroid, which is present in front side between thyroid and cricoid, which is the external muscle visible. And between the thyroid and arytenoid, we have the thyroarytenoid muscle, and vocal is present inside the vocal cord or the voice box. So these are the group of the muscles which is present. So let's categorize this muscle of the intrinsic nature of the muscle first. So all the muscles, whatever they are doing either a double deduction or they are doing some relaxation or doing some tensioning action. There is only muscle which is capable of doing abduction, that means opening it. So we memorize this way. So there is only muscle which is basically abducts. We call them as PCA, posterior cricoarytenoid. This posterior cricoarytenoid is the only muscle which is doing abduction. What do you mean by the abduction? That means it can spread the vocal cord. Now, why the spreading of vocal cord is important? Because unless it is spread open, the air cannot get through. So this posterior cricoarytenoid is the only muscle which can pull this muscle or pull this particular vocal cord wide apart and can make this particular rima glottidis wide so that air can go in and come out and we can breathe and survive. Now, what makes this thing more important? That is, this is the sole muscle that can do abduction. Now, you can imagine how powerful this muscle is. So, if we paralyze this one muscle by any drug or any means, we do not need a bullet, we neither need any knife or anything else to kill a person. Can you imagine the strength of this muscle? So, we paralyze only one muscle and we can kill a patient. We can kill a person. And this is how this thing is developed, which is the biological warfare, which we have famous or infamous gas is there, which is a neuroparalytic gas, which paralyzes this only one muscle. It's a gas there. We call them a serine. So that particular gas is a neuroparalytic to this posterior cricoarytenoid. That one muscle is paralyzed, knocks out. So this particular muscle, we call them as posterior cricoarytenoid, DS or posterior cricoarytenoid, is abductor of vocal cord. We call them a safety muscle of the larynx, which is understated, I would say. It is a safety muscle for life, isn't it? So this is what we have to remember, memorize this basic classifications of the larynx. We forget anything on earth, we cannot forget this posterior cricoarytenoid because this is the muscle keeping us alive. If it is knocked out, we are dead by right at this moment. So this posterior cricoarytenoideus or posterior cricoarytenoid is this particular muscle, is only muscle capable of abduction of vocal cord. Rest of the muscle do anything, any damn thing, they cannot do abduction. Clear? So these are the two basic classifications that you remember or memorize at the first. Abductor and non-abductors. And out of non-abductors, some of the muscles are relaxers, some of the muscles are tensors, and some of the muscles are kind of sphincters or closing it. So those things are next level of classification. If you absorb this first part, then you can go in the other part. So this is where we memorize. First we memorize this posterior cricoarytenoid or posterior cricoarytenoideus. Then we remember the rest of them. Alright? Now let's take it. So other than this posterior cricoarytenoid, we have this lateral cricoarytenoid. So this lateral cricoarytenoid which is present over here, and this particular arytenoideus, transverse and oblique. So these three are the muscles, they are known as sphincter muscles. They are known as sphincter, that means they narrow it. Now how it works out? You're drinking a water, all of a sudden you choke. That means the air which you are swallowing brings the water along with it and you aspirate. That means the air is in the trachea. That means it's bound to go to the trachea, to this particular lungs and flood this. So we need to stop that. We need to close that. We need sphincters quickly. So moment over here, you have an aspiration. You need a sphincter muscle which can quickly throttle. And throttling it, it closes the air, it closes the water. And we cough out at the same time. That means it throttles and coughs out, so the water gets in, can be thrown out. This is how it works out. So this particular muscles, which is lateral cricoarytenoid and this transverse and oblique arytenoid or arytenoideus, they are sphincter muscles. That means they are closing suddenly whenever some foreign body gets in. Foreign body, peanut, water gets inside, this sphincter action. We need to close it, shut it down right away, right that point. So this is how it works. They are known as sphincter muscles. But they are not abductors. That means they are closing. That means they are adductors. They are tensors. They are stretching muscles. Other two. So they are thyroarytenoides and cricoarytenoids. One of them are relaxer, one of them are tensor. So this particular TA, we call them as thyroarytenoideas. They are relaxer muscle. And this cricothyroid, they are tensor muscle. So these two, I usually get mixed up between. So this thyroarytenoideas, I used to memorize TA. For the TA is a travel allowance. That means it's related to travel, and the travel relaxes. That's how I remember the thyroarytenoideas. It's TA and travel allowance and it relaxes. So that means this muscle relaxes the vocal cord. And the other one is doing the opposite, which is cricothyroid. So this is how this classifications of these intrinsic muscles of the larynx is based on that. Abductor, non-abductor. Out of non-abductor, sphincters and relaxers and tensors. This is how this thing works out. Abductor, this only one. This abductor, that's why you call them a safety muscles of the line. Safety muscle of the larynx. Explain why. Safety muscle of the tongue. Explain why. The same thing. Why it is called safety muscle. Then you have to narrate this muscle, how they are doing and what they are doing. We have to know a little bit about it. And abductors are rest of them. The abductors are also known as the sphincters. So this particular muscle that we are talking about, posterior cricoarytenoid. So between the cricoid and arytenoid, this is there posteriorly. So once this particular muscle contracts, this particular rima glottidis opens up. That's why this is abductor. So posterior cricoarytenoideas, this is how it is placed. So posterior cricoarytenoid is the muscle that we must remember or must remember. Then you move to this particular muscle which is known as the sphincters. The rest of them are sphincters like lateral and transverse and oblique arytenoideas. This muscle is required to shut it closely when you have the immediate aspiration happening there. And rest is relaxer and tensors, which is we can figure it out and do it. And the vocalis which is present within this vocal cord, lengthening and the shortening of the vocal cord is doing over there, producing this particular pitch of the voice, louder or lesser. That's what you have to know. So this is how this particular thing works out. Now this all important thing about this larynx is the nerve supply to this particular muscle. So all the muscles of the larynx is supplied by the recurrent laryngeal nerve. So all the muscles of the larynx, that means intrinsic muscles of the larynx. So all the intrinsic muscles of the larynx is supplied by the recurrent laryngeal nerve except one which is known as CT, cricothyroid, which is supplied by this particular. So all the muscles of the larynx is supplied by the recurrent laryngeal nerve except one, which is the cricothyroid, which is externally placed and supplied by the superior laryngeal nerve or external branch of superior laryngeal nerve. So again, coming back to the same first thing we have talked about. We talked about the membrane between the hyoid and the thyroid, thyrohyoid membrane. We mentioned that there is a nerve which is known as superior laryngeal nerve, which has a two division, external division and internal division. The internal division goes through there and gets inside the larynx, and the other one, which is external division, drops down and supplies this cricothyroid muscle. So this particular cricothyroid muscle is the only muscle which is not supplied by the recurrent laryngeal nerve. Of course, the intrinsic muscles of the larynx. And how this thing comes out is this. This is the superior laryngeal nerve. It has a branch which is getting inside, internal laryngeal branch, and the external branch drops down, coursing through this larynx, supplies this cricothyroid muscle, which is present between the cricoid and thyroid in this region. So this is the blood supply, nerve supply, which is motor supply is concerned about this particular, the muscles, which is the intrinsic muscles of the larynx. Now let's talk about the sensory supply of this. So the sensory supply of the larynx is again supplied by the two nerves. So above vocal cord and the below vocal cord. The below vocal cord, the nerve supply, the sensory supply is coming from the recurrent laryngeal nerve. The same recurrent laryngeal nerve which is coursing from below has an internal branch, supplies the interior of the mucosa of the interior of the larynx below the vocal cord. Above the vocal cord, it is supplied by the internal laryngeal nerve, which is a branch of the superior laryngeal nerve. So this nerve supply of the sensory supply, that means touch, pain, temperature, which is the internal branch of the superior laryngeal nerve, which is the branch of vagus, anything, recurrent laryngeal is also vagus nerve, which is supplying. So sensory nerve supply to this mucosa of the larynx above the vocal cord is coming from the superior laryngeal nerve, internal branch of it, and the recurrent laryngeal nerve supplies the mucosa below the vocal cord. Again, we have to remember this as a word of religious books. Coming from this nerve supply, the other thing which is also there, which is known as the blood supply and the lymphatic supply. So this particular blood supply and the lymphatic supply is again superior laryngeal artery and this inferior laryngeal artery. They are supplying these different regions of this larynx, above vocal cord, below vocal cord. So superior laryngeal branch, which is a branch of superior thyroid artery, and inferior laryngeal nerve, which is a branch of inferior thyroid artery. They supply this particular larynx in the upper half and the below half. That means vocal cord above, vocal cord below. They are supplied by these two arteries, superior thyroid arterial branches and inferior thyroid artery branches. They supply this particular larynx and vocal box accordingly. The venous drainage, according to this particular arterial drainage which follows here, goes to the superior laryngeal veins and inferior laryngeal veins, drains to this particular internal jugular vein and the brachiocephalic vein. So these are the two divisions. And the lymphatic drainage, again the same. So above the vocal cord and below the vocal cord. Above the vocal cord, it drains to the superior cervical group. Below, it is going to the inferior deep cervical group. So this particular nerve supply, blood supply, and the laryngeal lymphatic supply are likewise, we have learned the similar phenomenon, just like it happened in case of the anal canal. So above the pectinate line, below the pectinate line. The same thing over here. The line over here is the vocal cord. Above the vocal cord, below the vocal cord. The sensory supply, the motor supply. The blood supply, above and below, and the lymphatic drainage likewise above and below. The muscular supply, all except one. This is how this particular thing. And the different functions of the muscle, all except one, is doing this particular abduction. That's why we talk about. Now, this is what we call them as laryngoscopy. There are two forms of seeing the larynx or vocal cord. So there is known as direct laryngoscopy and indirect laryngoscopy. That's how we see this particular larynx. And this particular larynx voice box is seen over here in this particular clinical examination. So this is what we call them as indirect laryngoscopy. We are not seeing this particular larynx directly. We are reflecting through a mirror and seeing it. So you put this particular mirror like this and putting through the oral cavity and ask the patient to make a sound, and we can see this through the larynx. We call them as indirect laryngoscopy, and we are seeing the vocal cord. You can see this particular vocal cord and rima glottidis like this. So this is how the mirror is projected and picking up the image of the larynx and the rima glottidis. Then comes this particular other thing which is known as direct laryngoscopy. That means we put a camera like this and see this. And this is how this particular larynx in indirect laryngoscopy looks like. This black area is a rima glottidis. This is a vocal cord which is a white string, vestibular fold over here, and the vocal fold which is lying on this region that we have to understand. And this direct laryngoscopy, that means we are seeing this particular vocal cord through images. So you are going to see this particular larynx and you are seeing them through fiber optic cable cameras, and this is how it looks like in a real image. The vocal cord, this white strip we are seeing here is the vocal cord, which is in this particular position is narrow slit is there. That means this particular person is talking. That means the person, when we are examining, we ask the patient to just like try to talk. So whenever the patient is trying to talk, there's a narrow slit which is present over here. We call them as paramedian position. That means there are very thin slit of this gap which is present in this particular region. And normal breathing, it wides up, and this wides up thing which looks like triangular and wedge and narrow wedge structures which is going like this. Now, aspiration of foreign body. This is what we have to know about the clinical thing. Sometimes we get this particular thing happening. A foreign body by accident gets inside. For example, a person is taking a peanut or any small object, swallows accidentally. Immediate way, we can just like put these things out. We call them as Helmholtz maneuver. This is one of the maneuver that is life-saving. This is how it is produced. This is how it's done. We have to go in backside of the person, get inside over this lower rib cage, and target this epigastric region with this particular thumb. And we have to press it hard over this region and jacks it up. This thing keeps a negative pressure through this particular lungs, and air jacks up, and this particular foreign body, which is aspirated and lying in the larynx, can be moving up and thrown outside. So this Helmholtz maneuver is a life-saving, basic life-saving maneuver that we do that or perform that in a CPR or in a life-saving conditions whenever it's required to. So not all clinical thing we can cover over here, but this larynx is the important topic for examination, for practical, and for everything. So every corner of the larynx could be your exam question, and we can frame any point to exam question in regard to the larynx. So don't show up to the examination without preparing the larynx very well, or else you will be in deep trouble answering them. Cartilage of the larynx, mucous membranes, submucosal ligaments, cartilage and movement and relevant cartilages, and this particular vocal folds, vestibular folds, rhimaglottides, the muscles of the larynx, nerve supply of the larynx, movements of the muscles of the larynx, and along with this blood supply, lymphatic drainage, etc., etc. Everything related to the larynx is important.